The
This
aim,
conference will now be recorded.
facilitating conversations, sharing knowledge. Coalesce Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries. So, before we start with the sessions, I guess some of you will be new to the GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or the web page, you can find four icons at the bottom center: mic, camera, screen, and mic. Click on that to mute and unmute. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera. You can use this button to share or unshare the web camera. If you have the option to share the web camera, you can do it and it is completely your choice. Screen. Screen. You can use this button to share your screen. This is the main part during your presentation. After I call your name from my side, I'll be making you the presenter, and then only you'll be able to share your screen. So once I make you the presenter, you can click on the screen button and you will find a pop-up window to share your screen. And this is your fourth icon where you can use this to leave the session. On the top center, you can use the options to change your display settings. At the top right corner, you will have three icons: people, chat, and settings. In the chat option, you can chat with me or any other participants. So without any further delay, let's start the session. The first presentation is an oral presentation by Dr. Anton Tiotovano from the University of Technology, Sydney, Australia. Hello, Dr. Anton. Are you ready with your presentation?
Yeah, I'll just start discussing, I guess. I don't really have
Okay.
slides. I can just share my screen and go through the paper and talk.
Okay.
Uh,
Yeah, I'm making you the presenter. Please click on the share button to share your screen.
okay. Probably this one. Can you see the
Yes,
screen?
yes. Yes, your
Okay,
screen is visible.
hold on a second. Um, and you can see me scrolling, as in you can see the
Yeah.
screen moving.
Yeah.
Okay,
Yeah.
cool.
Your slides are moving. Thank you.
Oh God. Okay. Yes, this work was actually, well, it was just recently published, what, this year, but the actual like operation occurred in 2022. But really, my journey started in 2021. So this kind of, with the theme of the whole like this conference being gynecology and obstetrics, the kind of topic of the work is surrounding pelvic surgeries, laparoscopic pelvic surgeries, particularly in the female reproductive system. So yeah, gynecology. Um, yeah, so it seemed to be the issue here was the ovary removal. So the patient didn't need the whole like removal of like the uterus and didn't need the whole hysterectomy. The condition the patient presented with was um, the heavy periods. So the patient was transgender. The patient takes testosterone, but they were complaining about heavy painful periods. So the testosterone was supposed to suppress the periods, but that wasn't the case here, and so the patient went to doctors to see for kind of like, surgery is kind of like the last kind of option. So, but the kind of prior, not less invasive options weren't suitable. So surgery was an option here. And the minimal amount of like, surgical intervention needed to um, treat the condition was just removal of the ovaries. So the patient was in discussion with the doctors about a surgical intervention of this sort, but the patient didn't want the whole like thing removed. So um, at least the ovaries producing the estrogen was enough to treat the condition theoretically. And then obviously at the end, the periods did stop, which means it was a good thing. But the I think the important thing here is how the operation was um, conducted. Was that the patient had a very strong preference for no genital insertion, and I think that was that the patient had seen two surgeons prior to this surgeon, and there seemed to be some concern with some instruments being used in these pelvic laparoscopic surgeries in the female reproductive uh, structures, which is what this patient had. So the two instruments of concern were the catheter and like the urinary catheter and the uterine manipulator. So both seem to have an apparent purpose, but both are very easily avoidable with the right amount of preparation. Um, so because when you're doing the surgery, there needs to be enough room to be able to operate and move the instruments around. Um, but coming from a patient perspective, you're not really like you've never done surgeries before, so like you're kind of just putting your trust in someone you've never met the first time, but because they're a doctor, you're supposed to just like trust what the doctor is saying, and that's how a society is based, on this trust with our health professionals. But so how do we know what our doctor is saying is like for our best, for our care or not? So that's why it took till the third surgeon for this patient to be able to get this surgery without the having anything unnecessary happen to the patient, and it actually brings up a legal issue. But so I'll just say, like, 'cause, like the evidence is there is that you don't need to use those instruments. And I don't know about laws in other countries, but in the Australian law is that it's actually illegal to any unnecessary genital penetration. It's not medically appropriate, therefore it's actually sexual intercourse. And a patient consents to a medical procedure, they don't consent to sexual intercourse, and actually they don't know. That's the thing. And then so you're giving false consent, and that's what makes it illegal. But then the people don't know sometimes until afterwards or at the time, and then there's that weird in between of like, well, it's my preferred method of operation, and you'll be asleep when it happens. It's just, and then it's not professional and it's not appropriate. And according to our law, that I don't know, they haven't figured it out yet, but now someone's figured it out, and it could be that a lot of people might be in trouble. So I don't know. We just have to take it one at a time. But as far as my experience is that, I was happy that this procedure was done without it. It was a success to me from the images. Is that I'll go through this the patient. Yeah, like I said, transgender, needed ovary removal because of the periods. He was also complaining about pain, so that usually indicates maybe endometriosis. But he had the ultrasound, and the ultrasound, it didn't show anything. The ultrasound didn't show anything unusual. So usually with the endometriosis, until you actually go in the abdomen laparoscopically, and do like an inspection of the inside, then you'll find out if there's endometriosis or not. But usually a good indication is that if the patient complains of pain during periods, then that's an indication of endometriosis. So it was kind of like like a one, you do everything in one go, because you want to minimize the amount of times you have to like go and put a patient through surgery to go into their abdomen. So it was like, okay, well, we'll remove your ovaries, but if there's endometriosis in there as well, we can remove that as well at the same time. So that's what happened here. So it ended up that the patient did have some mild endometriosis. I've seen worse cases, but this one was quite mild. I think it was just like two patches. But um, yeah, the most the important part was the patient having the ovaries removed. Um, so yeah, they had blood results from like uh, back from 2015. It just seemed like the hormones were all over the place. Like we put it in a graph. It was like it's like way out of range. It's just like it's like extreme up and downs. It's just that I can't imagine that to be healthy. You want your hormones to be in the healthy right range for whichever like gender the patient is like trying to identify with. That's the important thing here. The gynecology is like often associated with like women, but like you can get male patients with gynecological structure. And I think that's a bit kind of like progressive that I see on social media. There's like, yeah, men being pregnant now, and I don't know, some people like aren't happy about that, but it's like I don't know. It's just like you start off with like different races and everybody like it it mixes together, and so I don't know. It just takes some time for society to accept it. And yeah, so that was the patient here was transgender. So they just wanted the minimal amount of like organs removed. They didn't want the whole thing removed. So it was just like we'll just remove the ovaries and the fallopian tubes because of like it reduces the future risk of cancer. The patient was happy with that. Right, and then the whole thing here was that it was like minimally invasive surgery, which means like we try and like not disrupt the patient, like meaning like we try and get them back up and running as soon as possible. So that meant like no overnight stay. It was a day procedure. That's normally the case for laparoscopic surgeries. Um, yeah, and then definitely no catheter, no urinary manipulation, so no insertion in the genitals. I think that was the most important part for the patient here, um, where they were trying to balance out the whole like the safety and risks of the procedure while also trying to make sure we keep the patient not in distress, and that was how they wanted their procedure done, was that not through the genitals. But alternatively, I know some women, they're like they don't want scars on their abdomen, so then they opt for uh, the removal through the vaginal way. Um, so, and what I'm seeing here is that it's either one or the other. You can't really have like the both, because then it does get into the like you need an actual like sole proper reason for uh, any sort of genital insertion. So like I'm thinking like like pap smears, for example. Like there's no other way to get to the cervix but through the vagina. Then that would be medically appropriate, but it's not. It doesn't seem to be like, well, it's optional. Like it's an abdominal procedure. Like I say, the ovaries are in the abdomen. The ovaries have nothing to do with like the outside, the genital or anything. Not that area. It's like it's in the stomach essentially. It's in the abdomen. So you don't want to be tricking patients. They're vulnerable. That their genital system better than they do. So I think that's where some people can take advantage of that to then uh, yeah, do something that is not very appropriate. And we hold doctors to a high standard, so there's a very fine line between, especially for surgeons, like um, a very fine line between, what is medically like necessary and appropriate, and where you're actually then harming the patient when it's not necessary, and then and then it can get to like like assault, and so then yeah, it's a very uh, multidisciplinary field, I think. And I think we need to create like some sort of standard. There doesn't seem to be like a everyone's saying different things and the information's all over the place. So I think it's great now that we have, especially since COVID, we have all these like we're able to all come together to like have these meetings virtually, and we're not like obstructed by like these international like barriers. So I think now that when we're all coming together like these in these conferences, that we can all get on the same page, and this central standard of what is like, you know uh, the current standard of care is more like a globally adhered to. But yeah, anyway, this patient, no urinary catheter, no uterine manipula, and no overnight stay. So very it was yeah, quite specific. Um, right. So apparently it's not new. So this is not new. Like the use of these instruments, this work isn't entirely novel. It's more the fact that the information isn't quite like fully disseminated yet. That there still seems to be some sort of confusion. And this is like just another instance and case where, yeah, this operation has been done without it. But I've seen papers of like, yeah, we had a group that we used this, and we had a group where we didn't use this. Um, it just seems to be optional. Where I'm saying, well, actually, I don't know, like it like it definitely, like, you definitely cannot use it in some instances. You definitely cannot use it because it is actually a crime, and that's why I think that's kind of where we're at right now. And so but surgeons aren't lawyers, and lawyers aren't surgeons, and same like when you go talk to the police, they're like, well, it's a medical matter, and it's a matter for the medical council or the medical board. Uh, but then when you talk to the medical board, they say, well, it's a criminal matter and you should go to the police. And then they just keep passing it back and forth between, and nobody's working together. So, well, that's why I'm here. I just kind of like bring the whole thing together. But yeah, so in Australia, we have a Medicare system. So it's either like you get it covered by the Medicare, or you go through the private route and you have to self-fund the surgery. Um, so you give the patient the option. If they can wait, then the government can subsidize the surgery, or if it's a if it's so severe that and they have money, then the self-funded private method would be better. So here, yeah, the patient was like, yeah, I've waited so long for surgery that yeah, um, it's better if I just pay for it myself, and then I have it done in the next month instead of waiting for another year. So, uh, but yeah, it turned out to be like about $8,000 Australian, which is, well, it depends. If you're a full time worker, and you're earning like six figures, and this amount is like reasonable. But if you're like a student and you're on like a student welfare, then it's quite a lot of money. So it kind of depends, yeah, what your income status is. But ideally, I think these surgeries should be, yeah, for those financially disadvantaged groups of people. These surgeries should be covered by the government, and they shouldn't even have that wait list. But um, maybe that's later down the track. So yeah, it was about 8 grand Australian. Right, yeah. So then, yeah, I guess the patient was happy with his surgeon. The surgeon like offered the patient like the 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 method that one I believe was correct and was the appropriate method, and the patient was happy with that. The surgeon was able to do the surgery in this way, in this method. Um, so I know normally you guys make the patient take some sort of like laxative solution a night before the operation, but from the experience of the patient, it seems that the laxative solution wasn't that good. And I actually just recommend you tell the patient to fast. And I think fasting is great. It's not meant to be like a. I don't recommend fasting all the time, but the whole point is to clear the bowels. And I think fasting is the most natural way to do that. And then like drinking coffee because that clears the bowels. So that's my recommendation. And then obviously, yeah, we need that bladder to be empty before the surgery. So yeah, but it's important to be hydrated. So drink enough water. Uh, I think it was like until the night before, and then stop drinking water. And then usually the operations are done during the morning, starting from the morning. So then when you wake up, uh, yeah, no water, no food, um, and then keep peeing. Make sure we keep peeing. Um, and then right up until the patient goes to the hospital, gets admitted. They do the nurses and stuff. They do all their checks. Um, then check the patient's bladder with the ultrasound. Make sure the bladder is actually properly empty. Definitely as much as you can avoid catheter, because I think catheter introduces a whole risk of like UTI and all other risks. It's just I don't think it's natural to put stuff up there anyway. I think it's only like at like if the patient cannot empty their bladder and they've tried and there's no other option, then it's like a last resort then to use the catheter only, and then only with the patient's consent. So the consent is the important part here. um, right, so bladder empty, the patient's ready to go under. Right, I only know like what the surgeon did like based off some notes she gave me and the photos she took while she was in the abdomen. From what I know is that she put the patient on an angle, and that helped kind of help with the gravity to pull the uterus down into the abdomen. So instead of having the instrument pushing the uterus uh, towards the front of the, I don't know, abdomen, is that you kind of have gravity to help pull it in that direction, and that helps kind of stretch the uterus out and help to kind of reveal the structures of the uterus a bit better while you're performing the operation. That was my understanding. So to have the patient on an angle. And then only 4 incisions were made. So this was very much a laparoscopic surgery, laparoscopic keyhole, minimally invasive. There was no C-section or opening up the patient. We definitely avoid that at all costs. Um, this is like the modern day procedure. Right, yeah. So the main port being in like the umbilicus where the belly button is, and that's where the camera goes, and that's where they pull everything out through there as well. That's going to be the largest incision. It's still quite a small incision, but that's the largest port when they put all the openings in the abdomen. Um, and then the other 3 incisions at the bottom of the pelvis are there to, or the instruments helping uh, cut away the organs that you want to remove. So I think for this patient hasn't had children, and they're still quite young. The patient was, I think, 23 when they had the operation. So yeah, you can see their uterus is very tiny. So even if they did have a full hysterectomy, I still reckon they could have pulled that out through through the umbilicus from the belly button port. So that's the thing is like once you have control of the uterus, but then how are you pulling everything out? So uh, I still think even especially for the transgender men, people who have the vaginal stenosis, I think it is. It's just like the this the same probably like a width of like opening. It just like it's again it's like seems to be optional. Like you want to pull it out through here or pull it out through there. Like you must avoid like anything unnecessary with the genitals. If you can pull it out through the umbilicus, you have to pull it out through the umbilicus. I think that is the law. So, but like I said, surgeons aren't lawyers and the lawyers aren't surgeons. I think I have like 5 minutes, but uh, yeah, essentially, yeah. So that's what happened. So they kind of had a look around. They saw the endometriosis. They pulled the endometriosis. Well, they lasered it off and then pulled out the pieces of the endo. And then they cut away the ovaries, the fallopian tubes, and they removed it through the umbilicus. And everything was fine. Everything went well. So um, yeah, but it's more like the management of the uterus. It was a tiny uterus. I was like, definitely, if they use this uterine manipulator, it would have been inappropriate. It would have been unnecessary. And even the time it takes to set up that instrument, it would just be quicker just to use like, the forceps that you've already like put in the abdomen. So I can just see this being like a very concerning is all I'm saying. They're very easily avoidable and unnecessary. But yeah, so operation went well. The patient woke up, but it was very shocking. I think this is the normal reaction is that the patient's mind has to catch up what's happened to its body. And just having instruments in your body is just like your mind goes into shock. So yeah, the patient had to get given like medication and then they calmed down. Um, yeah, and then they stabilized, and within I think it was like 3 hours. By 3 o'clock, they had the operation started at 7:30, and then by like three, they were like peeing, everything was fine. Yeah, they were ready to be discharged. So it was good operation. Uh, yeah, they had the dressings on, and then I was just surprised about the scars later. This was like 3 weeks after operation. You can't even see the scar of the umbilicus, and that was where the biggest port was. And then you just see the three scars from the three ports at the bottom. They're very minimal though. Actually, yeah. And so the patient was up and walking pretty much on the same day. I think within 3 days they were back like driving. Um, Going to the shops, things like that. Obviously, not like doing like heavy exercise, but I'd say this is definitely like this is what minimally invasive surgery is. Like, they're basically like, you want to avoid like long hospital stays, and this is, in my opinion, this was not difficult. This is very achievable. I don't know. This is in Australia with a very like, we have a very high standard of care, and our technology is like uh, a bit more advanced than maybe other parts of the world. But um, I hope this sets like a benchmark, saying this is where we're at, and where maybe other countries, you know, where they're at as well with it in terms of their operations. Um, Yeah, and so yeah, it was a success. The patient's hormones came back into the correct levels with some minor adjustments. Like this graph compared to like the graph we saw earlier with like this was like a big change, and I can definitely tell like, and I know because like the patient was very happy afterwards. um, Yeah, so and another thing, just to finish off, another thing is like the medication you give to the patient after the surgery is that the patient actually preferred medicinal cannabis. Is that medicinal cannabis has the same like analgesic effects without the calm down that opioid-based medications seem to have. So that's just another suggestion. Because in Australia we have legalized medicinal cannabis. It is a safe substance. But if you're a new user, it's to be like careful with the dosage. Um, but in a safe environment, it's a nice soothing medication. Yeah, so overall, it was a good experience. Yeah, no unnecessary genital penetration, all laparoscopic. Patient was happy. Yes, I would hope to see more surgeries like this in the future. Um, yes, and I think I finish at the 25 mark, so I think I'll stop here. But yes, I don't know. Is there like a question time or something? That's normally how
Thank you, Dr. Anton, for your wonderful presentation. Does anyone have any query?
I guess not, but thank you for letting me present.
Yeah,
Hang
hope
around
there
for
are no queries. Yeah, hope there are no queries. Thank you once again, Dr. Anton, for your wonderful presentation. Okay,
thank you.
by this, let us thank you. Let us move on to the next presentation. The next presentation is by Dr. Tamar Weinstock from the Ben Gurion University of the Negev from the Israel. Hello, Dr. Tamar. Are you ready with your presentation?
Yes, I am.
Okay, I'm making you the presenter. Please click on the share button to share your screen.
Can you see it now?
Yeah, your screen is visible. Please make it a full screen and start your presentation. Yeah, that's
Okay.
perfect. Please go ahead.
Okay. Good morning, everybody. My talk today is going to be about urinary tract infection in pregnancy and GBS colonization, lessons from more than 1 million urine cultures. I'd like to thank the committee for letting us present our results. My co-author is also here, Dr. Israel Yoles. Hi. So I'll give you a little bit of background. GBS is from a gram-positive bacteria family. It colonized usually in genital and lower GI tract of about 10 to 14% of the women. Also found in the upper GI and the nose and throat. It may pass to the newborn during the peripartum by ascending infection or during birth. What we see here is the possible effects of GBS during pregnancy. It may affect the fetus and the mother. It may cause preterm labor or spontaneous abortion, sepsis and bacteremia, mastitis, hemorrhage, UTI, and possible death. As for the fetal, it may cause spontaneous abortions, preterm birth, stillbirth, pneumonia, sepsis, and meningitis, and that's obviously in the postpartum period. So it may be without any symptoms, but it may cause very severe outcomes. As for the neonatal infection, it may be either of early onset within 12 hours after delivery. Then it may be associated with bacteremia, pneumonia, and meningitis. 50% of the babies who develop GBS meningitis will be left with some level of long-term disabilities such as CP, deafness, blindness, or learning difficulties. Mortality of early onset of GBS is 1 to 3% of term infants And we can see a very big difference between the term and the preterm infants. There we see a 20 to 30% of mortality. As for the long-term onset, usually it develops within 36 days. Then we usually see bacteremia and meningitis. Obviously, as we can see, these are not as severe as the early onset. As for the neonatal infection, we see that about 320,000 infants cases of GBS infections through which occur yearly globally, and 57,000 stillbirth and 90,000 infant birth in 2015. And 1 in 10 babies infected by GBS will die. As for screening for GBS, which is recommended for pregnant women for these reasons, it may be either universal screening for all pregnant women, especially women who are planning to deliver vaginally, or it may be individual risk-based screening, which means not all women will be screened, but each woman will get a score for her risk, and based on that, she will or will not require to have screening for GBS. In the US, the ACOG committee opinion, we can see here, they recommend performing a universal GBS screening between 36 and 37 weeks of gestation. And that's one of the approaches, again, universal screening. And in Europe, what we see is, like for instance, in the UK, GBS is not routinely, the screening for GBS is not routinely performed. In Europe, some countries recommend either antenatal GBS screening or high-risk based strategies, or any combinations, and others do not even have any screening guidelines, and some do not perform the GBS screening at all. I want to talk a little bit about UTI infections in pregnancy. Urinary tract infections are most common bacterial infections during pregnancy. Organisms that cause urinary infection are those from normal perineal flora. Most of them are E. coli. Usually they present with no symptoms, and may lead, however, they may lead to pyelonephritis usually in the left if it's untreated. And usually we see the symptoms on only one side. It may be seen as acute cystitis, and symptoms include pain or burning with urination, frequent urination and feeling of needing to urinate, and fever. And pyelonephritis, which is the more severe cases, involve the kidney, obviously, and symptoms of acute cystitis plus back pain, and may lead to preterm labor, severe infection, and sepsis. Why these are caused during pregnancy, it may be for several reasons. First of all is the progesterone, which causes a hypomotility of the uterus, increased blood flow to the kidneys, which increases the glomerular filtration and increased urinary output. It may be caused due to the increased size of the renal and hydronephrosis, and increases the size and the increasing size of the uterus. All of these may lead to increased chances of UTI during pregnancy. It is usually characterized by no voiding or urgency or higher frequency, but usually are not symptomatic. It may be found that bacteremia may be found in screening and not due to complaints. And sometimes it's you can see microscopic hematuria it's common, and occasionally there are gross hematuria from hemorrhagic cystitis. Although cystitis is usually uncomplicated, the upper urinary tract may become involved by ascending infections. Also, almost 40% of pregnant women with acute pyelonephritis have preceding symptoms of lower tract infections, so that may lead to more severe disease. The complications, as we mentioned, is the possible pyelonephritis, which is the most common serious medical complications of pregnancy. It develops more frequently in the second trimester and among nulliparous women at a younger age. And it's usually, as we said, unilateral and mainly right-sided. It may cause premature contractions and preterm birth. It may cause respiratory infectious insufficiency to the mothers. Usually, as we said, it's caused by E. coli, and the second bacteria usually involved is Coalesce pneumonia. We can see here the pathogenetics of urinary tract infection and how it may ascend from the colonization around the urethra and goes up to the kidneys. Usually the origin of the colonization is from the area from the urethra, and it goes up, and the origin is usually from the GI system, and this is why we hypothesized that UTI infection and GBS may be associated with each other, meaning women that have UTIs during pregnancy may be at higher risk for GBS. Currently, as we said, many women are going through screening during pregnancy to identify the GBS and will be treated with some kind of antibiotics during pregnancy. But not all cases are, first of all, symptomatic, and not all cases will be dangerous, obviously, for the offspring. And the antibiotics may not be needed for all women, and the GBS screening may not be needed for all women. So if we will be able to identify women at higher risk for positive GBS, then maybe we can limit the screening and maybe limit the need for, well, not need, but the prescription of antibiotics. So it's reasonable that UTI may be associated with GBS infection because they may originate from the same origin. And again, if there's an ascending infection, it may be either to the uterus and maybe to the urethra. We aim to look at the association between UTI and GBS colonization. And we also looked if there's a seasonality effect on UTI during pregnancy. Is it more common during the summer because of the heat and maybe dehydration? So we looked into that as well. As for the materials and methods, the population included, what we see here is a map of Israel, and the central district is located here. The population in Israel includes 10 million people. From the Clalit, which is the largest HMO, we have over 5 million residents. And if we're including the central district, where the population in this study were from, this includes 614,000 people. And this is the group of women eligible. So we did a retrospective cohort study. We included all urine and GBS cultures from pregnant women between the years 2000 and 2020. We looked at the association between positive UTI in pregnancy and positive GBS cultures during pregnancy. As for the results, again, we included women who were pregnant between the age of 17 and 52 years. We had over 1 million results of urine cultures and 47,000 GBS cultures. All in all, we had 32,000 women who had both GBS and UTI tests. And as for the main results among women, and these are the main bacteria that we found. Again, as expected, the biggest one was E. coli, about 2/3 of the women. And for the main results, 20% of the women with a history of UTI had a positive GBS versus 15.9 women without a history of UTI, which also had a positive GBS. This difference was statistically significant, and women with a positive UTI who had a history of UTI were 38% more likely to have a positive GBS. The association remained significant while we also adjusted for parity, and the GBS, the risk for GBS was slightly higher among women with a history of recurrent more than one UTI during pregnancy. There, the risk we see, it was 20%, and here it was 21% if they had more than one UTI during pregnancy. We have not seen any seasonal variations in UTI incidence, meaning the summer, spring, winter, and autumn, they're all about 12% regarding the UTI incidence. As for the conclusion, women with UTI in pregnancy were at higher risk for positive rectovaginal GBS culture. Besides the well-known risk factors for GBS colonization during pregnancy, UTI may be recognized as another independent risk factor for positive GBS during pregnancy. I would like to thank you, and I'll take questions if there are any questions.
Thank you, Dr. Tamer, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Tamer, for your wonderful presentation. Let us move on to the next presentation. Thank you. The next presentation is by Dr. Talib Lashari from the Population Welfare Department or the Health Department from Pakistan. Hello, Dr. Talib. Are you ready with your presentation?
Yes, hello, Shirley. Thank you.
Yeah, I'm making you the presenter. Please click on the
Share.
share button to share your screen. Yes.
Yes. Open system. Give me a moment, please. Select it, share. I think it's a little bit.
Yeah. Once you click on the share button, you can find a pop-up window where you have to select the entire screen option. After selecting the entire screen option, please give access to the audio and then open your PPT.
Yes, I'm trying for that. I have given access to entire screen, and share button is not working, perhaps due to some reason. Let me cancel it and again do it again. Screen. I think there's some technical issue. Share button is not working. Chrome tab. Let me try.
Okay, okay,
Hmm.
Doctor.
I have
Um,
your, I have my presentation with you.
with
Can you?
yeah, you have your presentation with Lisa, right?
Yes, Lisa.
Okay, so okay, we'll share the screen from our end. Give me a moment.
L- l- Just a moment. I think it's now working.
Yeah,
Uh,
your screen is shared. Kindly open your PPT.
can you see my PPT now?
No, not yet.
Just a moment.
Kindly open your PPT.
Yes. Hmm, share command. I think there is some
Yeah, yeah.
problem.
Dr. Talib, no. Um, you can open your PPT. You cannot share that I mean, if you're still stay in the same tab, you cannot share. Open your PPT in the another window.
Okay, I'm trying for that. Okay, it's now open. I think you can't see it now. Yeah, still. I opened my PPT link, but I think it's not visible on the screen.
Okay, shall we share the screen from our end, Dr. Talib?
Yes, please. Yes,
Is that
please. Yes.
okay? Okay.
Yeah.
Please give us a minute. We'll share the screen from our end.
Thank you.
Hello, Dr. Talib. Is the screen visible from your end?
Yes, it's visible. Thank you.
Okay, yeah. Please go ahead with your presentation.
And sorry for this mishap.
And
uh,
for moving the slides, you can assist us with next slide so that we'll move the slides from our end.
okay, thank you. Thank you. So my topic is maternal neonatal child health in times of inequities, and I'll be focusing on a paper that I have prepared for this conference uh, in terms of what are the policies and what is their implementation and what are the inequities in our health system that are hampering the implementation of those policies, and how we are trying to uh, implement policies and programs. Next, please. Uh, the different sections in the presentation are global context, regional and context, MNCH progress versus inequities trajectory, policy initiatives to address inequities, and estimated impact of the policy initiatives, and conclusion. Next, please. I'll talk a little bit about the global context in terms of inequities. For instance, recent decades have shown that significant reduction in maternal, neonatal, and child mortality. Yet deep inequities still exist between and within countries. During past 20 years, 34% maternal mortality reduced globally. Still 95% maternal deaths occur in low and middle income countries. Maternal mortality increases 28% in intense conflict areas, which are definitely going on in different areas, regions in the world. In 2020, 1 in 10 babies were born preterm, and half of under 5 mortality will take place at neonate period, and 19 million stillbirths will take place till 2030 due to health and social service disruption, especially natural disasters, climate change, conflicts, and COVID. Next, please. Objectives of my paper were to examine through secondary data the impact of interventions in family planning and reproductive health in rural, remote, and peri-urban areas of Sindh province in Pakistan, which is a southern province in the country. The method that I used is secondary data drawn from Pakistan Demographic and Health Survey, population census of Pakistan, multiple indicators cluster survey, which is mix, Pakistan maternal mortality survey, CIP, which is costed implementation plan, the database of CIP, and data was compared for outcome indicators, inequities at sub-provincial and sub-district level, and finally, some of the conclusions are made. Next, please. I have seen inequities in terms of human capital, poverty, climate change, and health. And a little bit about human capital, which is about attainment of quality life in terms of health, education, and skill development. Human capital is a composite of knowledge, skills, and health that people accumulate over their lifetime. Next, please. Next, okay. Uh, this slide talks about human capital index. Basically, I've started with human capital. What are the disparities in terms of regional comparison? This data from World Bank, and we can see that the score from 0 to 1 Pakistan stands at 0.41 of the total score, while other countries which are comparable with Pakistan are Afghanistan, Iraq, and some other countries. But highest score is for Sri Lanka, uh, Malaysia, even Iran, and Saudi Arabia. And other countries are in between. Next, please. Now let's talk about the Human Development Index, Pakistan, in terms of demographic and gender gap within country. So this comparison of gender and within provinces. So if you look at first two bars, Pakistan, uh, men versus women, we can see that women are at lower level of human development. And likewise, in Sindh, in Punjab, we can, in Punjab, a little bit it's similar. In KP and in Balochistan, there are differences between human development of men and women. And we can see that two provinces, Sindh and Balochistan, which are southern and southern west provinces, they are having at lowest level of lower level of human development in the context of country. Next, please. Next, please. Yeah, thank you. Now I have compared in this slide through PDHS data that what is the effect of climate change. As you know, climate change, Pakistan is at one of the vulnerable countries in terms of climate change, and how health indicators are affected due to climate change. In the first column, you can see that uh, uh, Pakistan Agriculture Research Council has divided country into mainly two zones, less affected zones, which are mainly northern part of the country, and severely affected zones, which are southern part like Sindh and Balochistan and the South Punjab. So in these severely affected zones, you can see that the basic vaccination, uh, children who are stunted, wasted, and underweight, all these indicators are worst in severely affected. So there's a link between climate change implications with these areas, especially in terms of health of the children and and women. Next, please. Yeah, in Sindh, now I talk about the poverty. In Sindh, according to 2015 Planning Commission data, there's a differential between rural and urban Sindh province. You can see there's a stark difference between rural urban, whereby rural have the poverty head count of 75% and urban around 11%. But according to latest World Bank estimates, the rural head count has become less, which is 37%, because the data of 75.5% is way back in 2015. So there is definitely some improvement in the population poverty because of some of the social protection programs like Benazir Income Support Program and other programs. Next, please. Now we go to some of the health related indicators and look at the differentials. Pakistan's maternal mortality ratio is 186 per 100,000 live births. In terms of Balochistan and Sindh, you can see that in these two south and southwestern provinces, the maternal mortality is high, especially in Balochistan. And Sindh, it's 224. And while in North, you will see that the maternal mortality ratio is lower than the South. Next, please. So if you look at the rural and urban divide, there is, in Pakistan, the rural maternal mortality ratio is 199 or around 200, while urban is 158. So rural areas are more affected in terms of maternal mortality. Next, please. Here I have looked at the some of the health indicators which are essentially affecting the health of children and women, and I have seen I have noted that there is some progress, but inequities are also. So the trajectory of progress and inequities is compared here. You can see that in terms of neonatal mortality, infant mortality, under 5 mortality, birth by skilled birth attendants, institutional deliveries, proportion of ANC visits, proportion of postnatal care, contraceptive prevalence rate, prevalence of modern method of contraception by women, unmet need, total fertility rate, full immunization, stunted, wasted, underweight. In all these indicators, if you look at the PDHS 2012-13 and then to PDHS 17-18, there is improvement and there are achievements and progress is there in all indicators. But you will see that there are stark inequities in terms of urban rural. So whatever the achievements and the gains are there, these are nullified by the worst indicators in terms of rural areas. So this inequity persists, and we have to address that inequity through correct policies and timely investment and programs. Next, please. Here I have shared for you a slide from the CIP database, and we have seen that during the COVID 2021, you can see that in the peak time of COVID, in the month of April, May, June, even July, the family planning services were severely affected, and these services were almost near to lowest level in April and May. But later on, these improved as we would have been able to control the COVID. So then we improved a little, and then finally we reached to highest level of provision of family planning services. So you can see that there is a clear impact of COVID, and that might have definitely uh, impacted the health of women in terms of maternal mortality, maternal morbidity, and number of population, people in the population. Next, please. So, in this entire situation whereby inequities still persist and we have achieved some improvements, what are the policy initiatives that have been initiated? For example, under the international commitment of FP 2020, Family Planning 2020, a costed implementation plan was prepared in 2015 and 2020, and due to that CIP or costed implementation plan, lots of reforms were introduced in the population sector, especially in terms of integration of population with health and engagement of the private sector. And I will show you one slide after this slide that what are the impacts of those reforms under CIP. Second thing that we have initiated is FP 2030 roadmap, and this is till 2030. And I'll show you the goals for the FP 2030. And especially we want to uh, transform social gender norms through a social behavior change strategy through to achieve the objectives of the roadmap. The third thing that is important to share is Reproductive Health Rights Act 2019, amended 2022. And this is RH Act, which talks about the mandatory services for the access of women to reproductive and sexual health services and contraception. And also this talks uh, about the investigation of maternal mortalities, especially the causes of maternal mortalities, and we are using a WHO criteria for that. And also this talks about the marital counseling, because it is very important and pertinent to have marital counseling of newlywed couple, so that they should know about the genetic disorders, they should know about the conflict resolution, and they should know about the contraception whenever they want to start. Um, uh, Finally, another important initiative is a World Bank and Government of Sindh joint program on 1,000 days uh, reproductive, maternal, neonatal, child, adolescent health, integrated health and population program. So I'll talk about a little bit on that as well. Next, please. So, as I mentioned, the impact of reforms under the costed implementation plan on FP 2020, we have been able to increase the contraceptive prevalence rate, especially the PDHS has noted that in the rural and peri-urban areas where we were focusing more for family planning services, the increase in CPR has been 4 percentage points. But unfortunately, we could not focus on urban areas where the CPR went down 3 percentage points. But here in this slide, you can see that after the PDHS 1718, we have estimated that the contraceptive prevalence rate in Sindh province uh, uh, raised up to 34%, while through Washington-based Trek 20, we came to know that it's 33%. So this is the third-party source that has also validated that there has been increase in CPR. Next, please. These are the goals for 2030 as per FP 2030 roadmap, and we'll be focusing on transformation of social and gender norms, and we want to achieve 57% of the CPR by 2030, likewise reduction in TFR and population growth. Next, please. As I mentioned, there is a promising program initiated through support from the World Bank, and I was one of the leading members to design this program. And this is a loan of 280 million US dollars. And for this, we have especially focused on inequities, especially the areas which are desert, delta, riverine, hilly, uh, and desert areas of Thar area and Achro and arid zones. So in these areas, almost 20% of the uh, lowest quintile population is living, and they are lacking health services and facilities. So I think that is very important to start this program. And here we can note that on average a government dispensary is 9 kilometers away from a basic health unit, so people are living far from the basic health services in these areas, and they are lowest 20% of the quintile, lowest quintile, which is 20%. Next, please. So here I have given you the glimpse of the target population. I mean, the population that we'll be addressing through this program is 9.7 million, or around about 20% of the entire population of the province, and the people living in these areas are having no access to services, and the community workers are not available in these areas. So if we address the inequities in these areas, I think we'll be able to increase our overall indicators in urban as well as rural areas. Next, please. So what are the expected outcomes? I've shown you the different indicators of health, like NC, assisted delivery, PNC, fully immunized children, CPR, IMR, NMR, and other indicators. And in this slide, we have calculated that what is the annual rate of change in terms of two PDHA surveys of 2013 and 2018. So for example, in antenatal care, there's annual rate of change of 2.5%. There's increase. So what will be the contribution of this program through support from the World Bank? There will be expected contribution per annum 0.6%. So we can add that into 2.5%, and we can make annual change that this project will be. I'm sure there will be more high level of increase and improvement in the indicators. Like assisted delivery, there is annual rate of increase 3.6%, and this project will aid 1% more. And likewise, in fully immunization, we can see that this project will aid 1.5% increase per annum. In CPR, it will have 0.25% per annum. There is a very slow change in the CPR historically, so these are very conservative numbers. Likewise, in IMR, NMR, under 5 mortality, there is improve that is noted, and expected contribution is also provided here, and in stunting and vesting as well. Next, please. So as per the conclusion, if you look at all these slides and inequities, generally policies are guided by evidence. I mean, this is the recent phenomena that policymakers and decision makers now focus on evidence, especially through the support of development partners and donors. So generally, we can say that evidence is being considered when we prepare the policies. But more political will is required to amplify the impact of policies, investment to enhance integration and quality. So these two things can improve if we enhance more on the impact of policies, not the process, but impact. More emphasis on universal health coverage, gender responsiveness, resilience for emergencies, and humanitarian crisis situation. I mean, these are some of the ingredients which are very, very important in the UHC approach. Multi-sectoral approach to integrate health, education, and social protection. These are very important areas, because if we if we ignore education and the role of education, we won't be able to really have impact on health. And if we ignore social protection, especially for the poor people, we won't be able to sustain the achievements made in health. So the multi-sectoral approach is very, very important. Human capital formation is very pertinent in terms of knowledge, skills, and health, because if you look at the indicators of health, and we don't move or support people in terms of enhancing their knowledge and skills, we won't be able to make dent in terms of health. Continued policy advocacy is very important because there are scarce resources, and sometimes some of the areas in health and population are ignored if there is no policy advocacy. Social and behavior change for transformation of social and gender norms are very, very important. Without changing social and gender norms, we won't be able to really uh, make these all reforms sustain, and this will also ensure, I mean, social behavior change will also ensure accountability. So these are important areas where we need to focus more, although these policies are focusing on those, but still we need some emphasis on these concluding points. Next, please. Thank you so much. And this is my email and WhatsApp, and you can reach out to me and we can work together. And now, if there's any question, I'm available. Thank you so much.
Thank you, Dr. Talib Lashari, for your wonderful presentation. Does anyone have any query? Okay, hope there are no queries. Let's move on to the next presentation. Thank you once again, Dr. Talib Lashari, for your wonderful presentation.
Thank
So,
you.
thank you. So the next presentation is by Dr. Suzan El Sharqui from the Alexandria University, Egypt. Hello, Dr. Suzan. Are you ready with your presentation? Hello, Dr. Susan. Are you ready with your presentation? Hello, Dr. Susan. Can you hear me? Kindly unmute yourself. Hello, Dr. Susan. Can you hear me? Hello, everyone. I think there is some technical issue with Dr. Susan's end, so let us wait for her for 5 more minutes. We will contact her through WhatsApp. Thank you. Thank you for understanding. Hello, Dr. Susan. Hello, Dr. Susan. Can you hear me? Hello, Dr. Susan. Can you hear me? Kindly go to the settings in your system and then give access to the audio. Yeah. Hello. Hello, Dr. Susan. Can you hear
Me
me?
now?
Yes, yes, you're audible now.
Yes, I can
Yeah, but I think there is some
hear.
issue with your network. Kindly check it with
Yes,
that.
I hear you.
Yes, yes, you're audible, but your network is very weak. Kindly check it with that.
What?
Hello.
Hello?
I Yeah, okay. Okay, I'm making you the presenter. Please click on the share button to share your screen. Dr. Susan,
Okay.
kindly kindly click on the share button to share your screen.
Okay, now it's
Yeah,
the
your
screen is
screen is visible.
appearing with you.
Yes. Yes, the screen is visible. Please open your PPT. Hello, Dr. Susan. Can you hear me? Hello, Dr. Susan. Can you hear me? Hello. Hello, Dr. Susan. Can you hear me? Hello, Dr. Susan. Can can we move on to the next presentations? Meanwhile, you can check with your network connection. Okay. Okay, everyone. Sorry for the inconvenience caused. Okay, let us move on to the next presentation. Then the next presentation is the poster presentation by Dr. Atia Rahman from the Burjeel Medical Center or the Star Care First Medical Center, Oman. Hello, Dr. Atia. Can you hear me? Are you ready with your presentation?
Yes, hello. Can you hear
Yeah, can
me?
you hear me? Yes, yes, you're audible. Okay, we are sharing the screen from our end. Kindly give
Yes.
us a minute. Yeah, thank you. Hello, Dr. Atia Rahman. Is
Yes,
the
please.
is the screen is visible from your end? We have
Yes, I
shared the
have.
screen.
Yes, I can see the
Okay.
screen.
Okay. Kindly go ahead with your presentation.
Okay, thank you. Hello, I'm Dr. Atia Rahman. I am the specialist gynecologist at Burjeel Medical Center and Star Care First Medical Center in Muscat, Oman. And thank you very much, the team, for letting me present my poster. In the poster, we have done in Oman a retrospective cohort study on the adverse obstetric outcome related to the patient to evaluate the impact on the patients of having polycystic ovary syndrome. So, in terms of this is the poster which you can see, and it's like on the screen, it looks like very congested. So, I have made it slide by slide. So, we can go on to the next slide, please. Can we go to the next slide, please? Yeah, this is the introduction. Myself and my co-author, Dr. Mohammad Munir, who is working as an honorary senior lecturer at Cardiff University, United Kingdom. Next slide, please. Uh, Next slide, please. Yes. Regarding the polycystic ovary syndrome, it's usually affect up to 1 in 5 women of childbearing age, and it is diagnosed by any of the two of the three criteria. It could be one, menstrual irregularities with ovulation dysfunction. It can be biochemical hyperandrogenism or clinical hyperandrogenism and polycystic ovarian morphology on ultrasound. Later, the next slide, please. Later, the polycystic ovary syndrome was diagnosed on the basis of elevated luteinizing hormone, LH, and raised testosterone. But due to some variations in the hormonal assays and pulsatile nature of the gonadotropin secretion, made it further precision in the diagnosis by adding the ratios of LH to FSH between 2:1 and 3:1. But still many of the women have not fulfilled this criteria because there are sometimes lab to lab variation in the parameters of checking the LH hormone and the testosterone hormone. And most of the people sometimes consider it 2:1 ratio as consideration for polycystic ovary syndrome. Some people consider it 3:1. So there are lots of variation. And then we used to use ultrasonic scanning when it was possible to easily and reliably count the ovarian follicle as well as measure the ovarian and follicular size. In addition, we used to check on the scanning the sclerotic stroma that could have been identified there. Whereas according to Adam et al., the Rotterdam criteria defines the ovary as polycystic if there are multiple cysts of more than or equal to 10 millimeters, 10 in number of 2 to 8 millimeter in diameter, arranged either peripherally around a dense core of a stroma or scattered throughout an increased amount of stroma. This became the basis of the diagnosis of polycystic ovary, which is now known as the Rotterdam criteria. And it is also known nowadays as polycystic ovary syndrome criteria. Next slide, please. Next slide, please. It has become more apparent nowadays that more women have only polycystic ovaries, which is called polycystic ovary morphology, than those who used to be called as polycystic ovary syndrome. The syndrome consists of the three criteria as discussed in the last slide. Anti-Mullerian hormone is of very importance and it is produced by the granulase or cells of the pre-antral and the small antral ovarian follicle. There is a correlation between the antral follicle count and the anti-Mullerian hormone levels. And it is hoped that the measurement of the anti-Mullerian hormone will be a diagnostic tool for the presence of the polycystic ovary morphology owing to the heterogeneity of the antral follicle count that it is manual and operator based, and anti-Mullerian hormone level which vary into parameters of the machine to machine and laboratory to laboratory. It has not been used for the diagnosis of polycystic ovarian morphology up till now, unfortunately. Whereas during a recent meta-analysis of the 24 studies of polycystic ovary syndrome, the prevalence across the globe has been revealed that the overall prevalence of hirsutisms were too much, and in Europe and US and Asia and Australia we have done the meta-analysis, and it was respectively showing as 13% in Europe, 11% in US, 15% in Asia, and the most was in Australia in regards of hirsutism, hyperandrogenism, ovulation dysfunction, and polycystic ovarian morphology. Next slide, please. The polycystic ovary syndrome is of more important in terms of the polycystic ovary mothers who became pregnant with this condition, and they are more vulnerable to the adverse maternal and perinatal outcomes, especially in chances of having high risk of miscarriages, increased risk of gestational diabetes, high risk of development of pregnancy-induced hypertension, and appearance of more prone for preterm labors, preterm deliveries, and operative deliveries. In the current literature, the perinatal risks were described as fetal growth restrictions, large for gestational age babies, meconium aspiration syndrome, low Apgar scores at 5 minutes, and there were more NICU admissions and perinatal mortalities. Nowadays, due to the research criteria in the endocrinology, especially the European Society of Endocrinology has defined PCOS into 4 phenotypes. Phenotype A, B, C, and D. The more prevalent are phenotype B and C, whereas the phenotype A is defined as hyperandrogenism plus ovarian dysfunction and polycystic ovarian morphology, which is 15 to 20%. Phenotype B, which is hyperandrogenism and ovulation dysfunction, 30 to 35%. Phenotype C, which is hyperandrogenism and polycystic ovarian morphology or ovulatory dysfunctions only in the polycystic ovary syndrome, which is the 35%. And the phenotype D is defined as having only ovulatory dysfunction and the polycystic ovary on the morphology. Next slide, please. There are different types of classifications available in terms of phenotyping of the polycystic ovary syndrome, whereas I have given in this slide, which is being followed by the Endocrinology Society of the Europe. So in this, there is an agreement between, there are multiple risk associated with the type A and type 2, especially the oxidative stress and the low grade inflammation has been identified as a long-term risk to the phenotype A and phenotype B, which are typically called as classical polycystic ovary syndrome. And they are more prone to have insulin resistance, more changes happen in the glucose intolerance, and they have diabetes risk in a very early outcomes. Whereas polycystic phenotype C and type D are at lower risk of having oxidative stress and the low grade inflammation. Whereas still it has not been defined and it has not been clear the correlation between the phenotypes and the parameters of the oxidative stress and the index of the low grade inflammation. Next slide, please. What we have used in our study, doing the retrospective cohort study, we evaluated the patient with the diagnosis of PCOS, which is the polycystic ovary syndrome, from January 2020 to December 2022 from a single OBGY unit in Polyclinic in Muscat. We found 262 patients aged between 15 to 39 years were registered with the diagnosis of polycystic ovary syndrome, out of which 1125 patients of the reproductive age. There were only 122 pregnant women with the PCOS patients who had singleton or twin gestation. Then we evaluated the adverse obstetric outcomes with the variables of GDM, preeclampsia, PIH, preterm delivery, mode of delivery, LGA, fetal growth restriction, miscarriages, stillbirth, congenital malformation, and assisted fertility. And the results, we found that out of those 1125, 23.2% were already diagnosed at polycystic ovary syndrome. And when they got pregnant with singleton or twin pregnancy, and they were aged between 15 to 39, the analysis showed there was quite a greater risk of GDM, preeclampsia, PIH, preterm deliveries, cesarean sections, large for gestational age babies, fetal growth restricted babies, miscarriages, stillbirth, congenital malformations, and they were also prone to have more assisted fertility for becoming pregnant. And up to 30% of the PCOS patients were overweight, and 46% were categorized as obese. We also suggested them to have an integrated lifestyle modification to reduce the weight and the hyperandrogenism and the other co-parameters also. So in the last of discussion, next slide please. Next slide please. Yeah. So in our retrospective cohort study, the polycystic ovary syndrome was strongly associated with preeclampsia, very preterm birth, risk of gestational diabetes was doubled. Neonatal borns to the mother with the PCOS were likely to be LGAs, large for gestational age, and had a higher probability of asphyxia during labor than those born to the mothers who are unaffected by the PCOS. It indicated that the women with the PCOS have a high increased risk of during the pregnancy of a high risk of obstetrics indication for instrumental deliveries and cesarean sections too. They should have been considered only on the basis of having polycystic ovary syndrome into the high risk category, whereas they were not considered at the time of registration. Polycystic ovary syndrome is associated also with an increased rate of subfertility, ectopic pregnancy, early pregnancy losses. And the postulated cases are an altered endometrial environment due to the natural killer cells that is now being in the research, and subsequent reduction in the implantation success due to the hyperinsulinemic environment and insulin resistance, and concurrent the hyperandrogenism that is due to the high testosterone level observed in those patients. The rate of infertility and early pregnancy losses have been estimated to be 15 times, that's quite high, and 3 times greater risk of having infertility and estimated risk of having the early pregnancy losses in the similar age group. And the perinatal outcomes of the infant born to the mothers with the polycystic ovary syndrome is significantly worse than those born to the women without PCOS. And this can be further exacerbated by the maternal diabetes, obesity, IVF pregnancies, and medication use. So in the conclusion, in the end, the next slide, please. In the conclusion, at the end, we would like to say that polycystic ovary syndrome in pregnancy is significantly associated and it significantly increases the risk of adverse pregnancy, fetal and neonatal outcomes, and pre-pregnancy planning. Regular monitoring and integrated lifestyle modification can reduce significantly the adverse obstetric outcome. And in the last slide, I have given the references from which I have derived all these parameters. And we have also written that we have no conflict of interest. Thank you very much for this presentation. I'm open to any questions if anybody have.
Thank you, Dr. Atya, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Atya, for your wonderful presentation.
Thank you very much. Thank you for the team
Thank
and
you.
you all people for inviting us for such a wonderful conference. It's very learning. Thank you.
Thank you very much.
Thank you.
Okay, by this, we move on to the next presentation. The next presentation is by Dr. Susan El Sharkawi from the Alexandria University, Egypt. Hello, Dr. Susan. Are you ready with your presentation?
Yes, I'm ready. Can you hear me?
Yeah, you're audible. Yes, I'm
Okay.
making you the presenter. Please click on the share button to share your screen. Yeah, now click on the share button to share your screen.
Okay, now it's shared.
Yeah, your screen is visible. Yes, your screen is visible. Please open your PPT. Yeah, yeah. Yes. Hello.
Hello. I think the uh
Kindly open your PPT.
okay.
Yes.
Now you
Yes,
can see it.
please. Yes. Kindly make your mobile phone or your tab into a landscape mode. I
Okay.
mean, place it in. Yeah. Now open your PPT. Yes. Make it a full screen, Dr. Susan. Make it a full screen. It is visible. Make it a full screen.
Save save and application is confidential. Application. Okay, I think we will I
Yes.
will now.
Hello. Hello, Dr. Susan. You have stopped shared your screen. Kindly click on the share button again to share your screen. Your screen is not visible now. Hello, Dr. Susan. Can you hear me? Hello. Hello, Dr. Susan. Can you hear me?
Perhaps it would be easier for her if she could send her slides across to
Yes.
yourself, maybe.
Yes. Okay. Meanwhile, we move on to the next presentation. The next presentation is a poster presentation by Dr. Viveka Singh from the Dr. L.H. Hiranandani Hospital and Research Center from Mumbai, India. Hello, Dr. Viveka. Are you ready with your presentation? Hello, Dr. Viveka. Are you ready with your presentation? unable to hear you, Dr. Viveka. Kindly check your microphone settings.
Hello?
Hello?
Okay, I am this presentation button is not working. Can I send you the presentation so you share it from your screen and
Sure,
I
sure,
can
Dr.
comment?
Susan. Yes,
Okay,
sure.
okay. I will
Kindly
send
send
I
it
will
to
send
the program manager.
what?
Kindly send it to the program manager through email or WhatsApp.
Oh, okay. Now
Yeah.
WhatsApp.
Okay, okay, Dr. Susan. Okay, Dr. Susan, shall we move on to the next presentations? Meanwhile, you send your presentation. Hello.
Okay, it's already sent.
It okay. So okay, we'll share your screen now. Give us a minute.
Oh, okay, it's okay.
Yeah, give us a minute. We'll share the screen from our end. Hello, Dr. Susan. Is a
Hello. Good morning for
yes, is a
everybody.
screen. Okay, okay. Hello, Dr. Susan.
Me, shall I start now?
Yes, yes. Please start the presentation now.
Okay, my name is Dr. Susan Sharqawi. I am Assistant Professor of Alexandria University, Egypt. My subspecialty is XP and infertility. Okay, so the thing we are going to discuss today, it's recent research we did about the effect of injecting slowly motile sperms in the XC cases with sex selection randomized control trial. Next, please. Next slide. Okay, these are the authors. Next. Next, okay. Okay, this research was self-funded and the authors have no conflict of interest to declare. Next, okay, introduction. Next, okay. In the biological normal sex ratio, it ranges from 100 to 106 males to females at birth. This um, this ratio will decrease gradually with age because there are greater natural vulnerability of boys than girls. And with the aging of this cohort, it will result at the end for fewer men than women in older population. Next. Okay, and in the very beginning, this sex selection was done for only medical purposes like cases when we want to um, avoid the risk of having babies, a male baby, for having Duchenne muscular dystrophy, for example, or hemophilia, the sex-linked genetic disorders. And then afterwards, this idea of family balancing emerged in the cases of couples that have a child of some sex and they want another child with the sex they are deficient of. Next. Next. Okay. We have sex selection for IUI and we have sex selection for PGD and XC. I will give a very small and short hint about this sex selection in cases of IUI, which is called microsort. The idea of this microsort is that they depend on the fluorescence glowing of the chromosomes after giving or staining the sperms with a fluorescent dye and passing this sperms through a flow cytometer, which is having the ability to distinguish between the two types of sperms, the X-bearing sperm and the Y-bearing sperm, according to the brightness of the fluorescence dye emission. Actually, this technique has proven to be 93% effective for selecting girls and 82% effective for selecting boys. The idea is to separate the sperms from the beginning, the X-bearing sperms from the Y-bearing sperms, and then use this treated semen for fertilization. Next. Okay. This microsort come with risks. Sometimes this sorting procedure might cause variation in the cleavage, in the fertilization, in the ongoing pregnancy rate due to abnormalities and the alteration of the messenger RNA expression patterns or the fertilization rate of the sperms. So there was some other selection methods criteria like the swim up method and Perkel density gradient centrifugation. They tried not to expose the sperms for this fluorescent dye and flow meter to retain the viability of the sperms and the ability to fertilize the oocytes. Next. Next. Okay. Sex selection for embryo transfer. This is the cases of VGD, which is the V-implantation genetic diagnosis, where we take a plastomere from the 4 to 8 cell embryo biopsy, and then we will examine this plastomere using the fluorescent in situ hybridization for detection of specific chromosome, or sometimes we use this PCR-based assay for specific gene identification. This PGD sex selection or chromosome examination and identification of this embryo, whether it is a boy or a girl, will not negatively affect this embryo after transfer. The main problem with this PGD examination of X case is that it have anticipated higher failure rate rather than other cases of XC because uh, in some cases, actually, we will not find the desired sex embryo for transfer. Next. Next. Aim of the work. Next. Okay. Actually, based on the difference in the swimming criteria of the X and Y bearing sperms, we suppose that the Y bearing sperm may swim more slowly than the X bearing sperm. This is the idea we started with, and try to compare whether this is going to be true or false in cases of XC requiring sex selection for family balance. Next. Methods. Next. Okay, this is a prospective randomized controlled trial was done from the period from January 2020 to July 2022, and then we have some months for preparing the data. This research was approved by the Ethics Committee of Faculty of Medicine, Alexandria University, and take the registration at the Pan-African Clinical Trial Registry. And we calculated the sample size according to a previous study in margin of error 5%, and the sample size calculated was 35 women in each group at least. Next. 132 patients, couples, seeking XC for sex selection, and they did 132 cycles of XC. Each couple did one cycle XC. Our workplace is a private infertility center in Alexandria called the Ingab Infertility Center. Of course, there was a written consent, and we used the flipping of a coin as a simple randomization to assign the couple in group A or group B. Next. The inclusion criteria. The couple seeking XC for sex selection for males only, and the age of the female partner from 20 to 40 years old of the female partner. Exclusion criteria was the couple seeking XC for sex selection for female embryos, and couple seeking XC for medical causes like female factor infertilities and male factor infertilities, etc. Next. Okay, the induction protocol, we used either the GnRH agonist or antagonist protocols, controlled ovarian hyperstimulation, and then we did this follicular monitoring and estradiol level monitoring of the cases, and we gave this human chorionic gonadotropin when 1 or 2 follicles reaches 18 millimeter inside, and we did oocyte retrieval was after 36 hours later. Next. As regards the seminal sample preparation, we used seminal samples after 3 days of abstinence by masturbation at the lab, and we did no, still the other one, the previous one. No. Just go back 2 slides. No, you are going forward. Go back. The previous slides. Hi, Miss Lisa. Can you hear me? No. Miss Lisa, can you hear me?
Yes, yes,
Okay.
you're audible.
Yes.
Yeah, we are moving the slides.
No, I don't need to move the slide. I'm still in the slide of the methodology. The next slide of the methodology. No, we are moving forward too fast. Please come back.
Okay, we're doing that.
The slide of the method. The next slide. Yes, the slide before this one. Go back 1 slide. Miss Lisa, go. Yes. No, another slide. Another slide back. Yes, that one. Keep here. Thank you. Okay, we have taken the semen samples after 3 days of abstinence and using the method of masturbation at lab. And then we used the swim up procedure for semen wash. And then this for semen micro selection, we used 1 microliter of this swim up sample in a PVB media. And then the sperms with apparent normal morphology and slowly progressive motility were selected and used to inject the cases of ICSI of group A. That was 94 cases, and the spermatozoa with an apparent normal morphology and rapidly forward progressive motility we used to inject the oocytes of the cases of group B, which is 38 cases. Next. All the patients had the embryo biopsy on day 3 after oocyte retrieval and injection. This pre-implanted, no, don't come back again. The previous slide. Okay, this one. Thank you. Okay, we did this biopsy for the plastobir on day 3, and then BGD to detect the X and the Y hearing, the females and the males embryos. And of course, we counseled the patient. As regards this result prior to embryo transfer and the possibility that she would not find a male as she required. And then cases who had male embryos, 1 male or 2 male or 3 male embryos, we transferred fresh male embryos. And as regards the cases that has 4 embryos or more, we transferred 2 embryos only, and the resulting embryos were cryopreserved for future trial. Next. Next. Okay. The data were collected as the female patient age, the number of the mature oocytes injected, the number of the biopsied embryos, the number of the males, females, or the non-conclusive embryos as a result for the BGD, the number of embryos transferred or cryopreserved, and the number of the cases that had biochemical pregnancy rate. Our primary outcome was the percentage of the male embryos in both groups, and our secondary outcome was the pregnancy rate in both groups. Next. Okay, results next. We had 132 patients underwent 132 XC cycles. All the participants wanted to have a male embryo and went for 1 cycle only. The 2 groups were comparable in the age, and there was no statistical significant difference in the number of in the total number of fertilized embryos or fertilization rate. There was a statistical significant difference in the number of meiosis II oocytes with higher oocyte number in group B. Next. Okay, these are the results of the PGD as regards the 2 groups. To summarize the results, we did not find any statistical significant difference between the number of the male embryos and the number of the non-conclusive embryos resulting in the 2 groups. But we have a significant statistical difference between the 2 groups as the number of the female embryos, that of group B. So group B had a higher rate of female embryos. Next. Okay. All embryo transfer occur at the blastocyst stage, which is day 5, fertilization. As regard to the results of this transfer or cryopreservation for later use, there was no statistical significant difference between the two groups in the transfer rate. But as regards the cryopreservation, we have a statistically significant difference between the two groups with higher rates of cryopreservation for the male embryos resulting in group A. Next. There was no statistical significant difference in the embryo transfer, but as I mentioned before, that we have higher rate of cryopreservation in group A. As regard to the biochemical pregnancy rate, we achieved 39.3% total biochemical pregnancy rate in both groups. There was no statistical significant difference between groups in the pregnancy rate. Next. Next. This is like a scheme of what we did. Next. Discussion next. Okay, in the cultures where the male children are expected to provide continued familial loyalty, heritage, and support to elderly parents, we can understand the strong prevalence and preference for the male children. In Egypt and other similar Islamic countries, giving a baby for adoption or voluntary abortion are prohibited by religion and criminalized by law. So it's the only legal way to get more boys is to do ICSI with PGD. The International Islamic Fiqh Academy and the Holy Azhar have allowed the non-medical sexual sex selection in restricted cases such as family balancing. If we practice the sex selection for family balancing, means after having 1 or 2 child with the same sex and requiring another baby with the other sex we don't have, this will not affect the equilibrium of both sexes in the community. Rather, it will decrease the size of the family and decrease the overall yearly purses, which will lead to beneficial effects on the country economy. Next. Next, please. In Egypt, some families may continue to have children until they have got a son at last. Since this frequency will elicit emotional reactions concerning these issues of that the families valuing only boys, not all the children, as a gift from Allah. So, sex selection in favor of boys, in my opinion, is a feature of pervasive social, cultural, political, and economic injustice against women, and a manifest violation of women's human rights. But at the same time, we can argue that it is still a human right to choose to get a baby or not, and to choose to get this baby as a boy and a girl. Such a wish that we cannot allege that will be harmful to anyone in the community by any means. Next. Mother Nature has developed many mechanisms to make this genetically different sperms phenotypically identical within the male. The only de novo difference identified till now between the X and the Y bearing sperm is the difference between the two sperms in the DNA content. The textbook said that the X sperms, the X bearing sperms have a more DNA content around 2.8% than the Y bearing sperm. However, this difference in the DNA content is still not proven to cause any physiological, chemical, or functional differences between the two types of sperms. Next. Next. Okay. The difference in the X and Y sperm motility have been studied extensively, but lead to conflicting results. Some reporters and researchers reported that the mobility of the human sperms, X and Y sperms, are similar, but when we change the stream from the steady stream to the flow stream protocol, this will lead to some shift in the motility of the sperms, the X sperm. Other researchers studied the effect of low pH, high temperature, high oxidative stress. That they found that when these changes will rapidly decrease and affect the Y bearing sperms, but the X bearing sperm will be more resistant. Next. Our result, we found that there was no statistical significant difference between the two groups as regard the total number of male or the non-conclusive embryos. But we have got more female embryos in the groups we used the rapidly moving sperms in it. And also we have got more embryos for cryopreservation in the group A, which we used slowly motile sperms in it. Next. We have always ethical concerns will come around or arise as this XCPGD sex selection that will be not favored but by some people who remain controversial for many of those who deny the use of science and technology in such a way that may alter the nature as we know it. Although it's more invasive, this PGD, other than ICSI, and it may lead to discard of normal embryos of the undesired sex, it is still more moral than doing this perinatal diagnostic tests for fetal sex and then followed by induction of abortion or putting the baby for adoption or something like this. This strong male preference observed in our sample in the Egyptian community, it reflects, of course, an obvious violation of women's human rights. That's my opinion. And I think that that preference cannot be resolved just by prohibiting the sex selection procedure. It needs more effort to improve the status and the value of women in the community and encouraging their complete autonomy and participation. Next. The study strength, I think this, according to the best of our knowledge, this is the first study was done in Egypt, studying the sperm motility for distinguish the Y and the X bearing sperms in the XC and BGD cycle. The other strength of the study that most of the cases we have were requiring male embryos. In this whole study, we just excluded only 5 cases that requiring this XT-PGD selection for female embryos. Next. Okay, the study limitation that actually this XT IUI infertility treatment, it's not covered by health insurance in Egypt. So it's very expensive, and this, of course, put some limitations for us and limit the cases we were able to study. But the procedure also is associated with a higher failure rate. So the counseling of the couples was of utmost importance, that they have to understand the issue that we may not find the boy you are looking for. The last thing is the biochemical pregnancy rate only. We were able to trace because many cases that have remote residency from our center, so we couldn't follow up the cases if there is clinical pregnancy rate happened or not. Next. Next. Okay. I think we may need more studies in the future. Okay.
This conference will now be recorded.
Okay, as a future study perspective, I think we need to design a study in which the cut value of sperm motility could be measured and identified, because in our study we used just the subjective. This is a rapidly moving sperm and this is a slowly moving sperm. I think in the future we may use need to use this cut value of sperm velocity, and of course larger studies with larger number of patients to more precise evaluation of this technique in selecting sperms for XGPGD cases. Next. Conclusion. Next. Our technique was able to simply distinguish between the Y and the X bearing sperms by physical characteristic motility. We found a statistical significant difference in the number of the females embryos produced by using the rapidly motile sperms. There was an increase in the number of the male embryos produced by using the slowly motile sperms for ICSI that were available for transfer and cryopreservation cases requiring male embryos. Although this procedure is not 100% accurate, but it's still a simple, non-invasive, and add no cost to the already expensive XCPGD procedures. Next. Thank you, and I'm open for any question. Thank you.
Thank you, Dr. Susan, for your wonderful presentation. Does anyone have any query? Okay, hope there are no queries. Let us thank you once again, Dr. Susan, for your wonderful presentation. Okay, let's move on to the next presentations. The next presentation is by Dr. Viveka Singh from Dr. LH Hiranandani Hospital and Research Center, Mumbai, India. Hello, Dr. Viveka. Are you ready with your presentation?
Yeah,
Hello,
good
Dr.
evening. I am ready with my presentation.
Okay, okay. I'm making
Hello.
you the presenter.
Yeah,
Yes,
I am
yes,
ready
you're
with my
audible.
presentation. Am I audible?
Yes, you're
Yes.
audible.
So,
I made you the
am I
presenter.
audible?
Please click.
Yeah.
Yes, you're audible.
Please do let me know
Kindly
in
click.
case I'm not audible anytime in between. Yeah.
Okay, sure, sure. Kindly click on the share button to share your screen, please. Yes, your screen is visible. Please open your PPT. Kindly open your PPT, Dr. Viveka. Yes, it's perfect. Please continue with your presentation.
Hello.
Hello. Yes, now
Yeah,
you're
am I
audible,
audible?
Doctor. Yes, now you're
Yeah.
audible,
Can I begin,
and
please?
yes,
And
yes,
is my
please,
screen visible?
please go ahead. Yes, your screen is
Yes.
visible. No, you stop
Right.
shared your screen now. Hello, Dr. Viveka. You have
Just hold on.
stopped
Just
shared
hold
your
on.
screen. Okay, okay.
Both of the PPTs.
Kindly check your network setting. I think there is a poor connection on your end. Hello, Dr. Viveka. We are unable to hear you. Kindly check your network. No, there is a lot of disturbance and we are unable to hear you. Kindly check it with your network settings.
Can I share the PPTs with you, please?
Sure. Actually, your PPT is visible, but we are unable to hear. There is an issue with your network, it seems. Okay, hello, Dr. Viveka, if you would like to share the PPT, kindly share it to the program manager through WhatsApp or email.
Hello. Am I audible?
Yeah, but hello, hello. Hello, Dr. Viveka. I think there is n- a network issue on your end. We are unable to hear you properly. Kindly check with
Hello.
your hello.
Am
Hello,
I
Dr. Vivek.
audible? And because I'm sharing,
Okay,
am I
okay,
audible to you?
no, Dr. Viveka. There is a okay, okay, Dr. Viveka. We will share the screen from our end. Is that okay? We have received your PPT. We will share the screen from our end.
Yeah, I can.
Yeah, stop share your screen. We will share the screen from our end.
Hello, can you hear me
Hello?
now? Am I audible
Hello?
now?
Hello? Yes, you're audible now.
Am I audible at present?
Hello, Dr. Viveka. I think there is a critical network issue on your end. Your voice is not clear. Your voice is not clear.
Yeah,
I think there is a network issue on your end. Kindly check it with your network settings. Network. We will share the screen from our end.
yeah, yes. Am I audible as of now? So should I, so a moment please to check it, and if you want you can, yeah.
Hello, Dr. Vivek. Yes, we have shared the screen from our end. Is that visible? Hello, Dr. Viveka. Is the screen visible on your end? We are unable to hear you, Dr. Viveka. Kindly check your network settings. Hello. Hello, Dr. Viveka. Can you hear me? Hello, everyone. Sorry for the inconvenience caused. Give us a minute. We will check it with Dr. Viveka and get back to you in a minute. Hope you can understand.
This conference will now be recorded.
Hello, everyone. Okay, I think there is a critical network issue with Dr. Viveka. Okay, we'll move on to the next presentation. So the next presentation is by Dr. Mayumi Kuroda from Department of Physical Therapy, Ibaraki Prefectural University of Health Science, Japan. Hello, Dr. Mayumi. Are you ready with your presentation?
I'm here, but I cannot
Okay,
share
okay.
the.
Yes, I'm making you the presenter now.
Yes, okay.
Yeah, I'm giving the access now. Yes, kindly click on the share button and share your screen.
Okay.
Yes, your screen is visible. Please make it please make it a full screen and start your that's yeah, that's perfect.
Okay. Nice. Thank you for the introduction. Hello everyone, nice to meet you. I am Claudia, a physical therapist in Japan. I specialize pediatric rehabilitation. I will now start my presentation. No COI to disclose at the time of this presentation. Damage to central nervous system during the developmental process in children leads to various disorders, including motor dysfunction and cognitive impairment, and these impairments progress from childhood to adulthood. The International Classification of Functioning Disability and Health, Child and Youth (ICFCI) was suggested by World Health Organization as a common framework to describe health and functioning. Therapeutic rehabilitation procedures can enhance body structure and function and individual activity or participation according to ICFCY. Cerebral palsy, a typical childhood onset disease, causes physical symptoms such as spasticity, muscle weakness, and a lack of selective motor control. ICFCI model for CP is shown in figure. Of CP patients who were ambulatory in childhood, more than 25% showed a decline in the walking ability in early adulthood due to joint pain and gait failure. Therefore, rehabilitation strategies for long-term maintenance of motor function are critical for rehabilitation of children patients. Currently, robot-assisted gait training is increasingly used in neurorehabilitation of patients with childhood-onset motor disabilities to complement conventional physical therapy. Several robotic devices have been reported to assist gait. Conventional robotic devices enable passive brake training by setting values for gait speed and roller rim joint angles. Thus, even a patient with an entirely paralyzed roller limbs can perform gait training by wearing the robotic device. Active patient participation, real-time control strategies, and voluntary muscle activation were considered important in order to achieve the best effect of robot-assisted gait training. Therefore, there is a need for a robotic device that increases kinematic variability and active participation of the patient during robot trainings. Thus, we focused our attention on exercise therapies using the hybrid assistive limbs. How is a wearable cyborg designed that can assist voluntary walking based on the intention of the wearer? So treatment to improve physical function. How can assist the wearer to talk in real time, walk in real time based on the wearer motor intention? Unlike other robots, movement occurs in response to wearer voluntary drive. For patients with motor disabilities, the use of HAL is expected to normalize gait patterns. The effect of training with HAL as intervention strategies to improve walking performance have been reported in adult patients with stroke and spinal cord injury. However, HAL is not labeled for use for CP and this remained investigational. The long-term effects of robotassist training using HAL are unclear, not only in young patients but also in adult patients. It is also important to clarify its safety and feasibility by long-term follow-ups. Additionally, in patients with childhood-onset motor disabilities, it is necessary to clarify the optimal intervention interval and timing based on growth and development. This study aims to investigate the long-term benefit of training using HAL in patients with childhood-onset motor disabilities. Patients underwent long-term follow-up with assessment before the intervention, immediately after the intervention, and at 1 to 3 months and 1 year follow-ups. 9 patients with childhood-onset motor disabilities were enrolled in this study. There were 5 male and 4 female patients with a mean age of 18. Diagnosis included CP in 7 patients, critical illness polyneuropathy in 1 patient, and encephalitis in 1 patient. About GMFCS, there is 1 level 2 patient, 7 level 3 patient, and 1 level 4 patient. Regarding the paralysis type, 6 patients present with spastic diplegia, 1 is spastic quadplegia, and 2 with paraplegia. Details of each individual are given in the table. This figure illustrates the disorder picture for each level of GMFCS. Level 2 and 4 were targeted in this study. This single-center observational study compares assessment results at 6 time points. Measurements are performed before and immediately after intervention and at 1 to 3 months, and 1 year follow-ups after HAL-assisted trainings. HAL treatment programs were performed for 20 minutes once a day. In total, the patient underwent 12 training sessions, completed over a 4-week period at 2-4 sessions per week. We examined gross motor function measure as a primary outcome measure. GMFM is an observational evaluation related to capacity for movement by changing of body position, carrying or movement object, walking, running, or climbing. For secondary outcome measures, walking speed, step length, and cadence were measured as indicators of walking performance. 6-minute walking distance was used as a measure of walking endurance. As a performance measure of daily living activities, we used the Functional Skill Scale or Pediatric Variation of Disability Inventory. We used the Canadian Occupational Performance Measure as a measure of participation. The effect of training, we utilize roller limbs time HAL size S, which considers of lumbar part with batteries, 4 actuators of hip and knee, and integrate exoskeletal frame from feet to the waist. How to use information from hip and knee angulator sensors, force pressure sensors in the shoes, and bioelectrics from the extensor and flexor muscle of the knee and hip joint. Further, the device sends biometric information regarding joint angles and robotic actuators are driven to assist torque. Example of training session. While walking and wearing how the patient uses a mobile suspension system to prevent falling during the walking activity. Statistical analysis were performed using SPSS for each value obtained before intervention, immediately after intervention, and at 1 to 3 months and 1 year follow-ups after heart training. Difference before and after trainings were analyzed using non-parametric Wilcoxon-matched pairs test. Long-term efficacy was tested using one-way repeated measures. All 9 participants completed the wearable robot assist training without adverse event. The average walking distance during heart training significantly increased from the first intervention to the final intervention. When the measurement before and after intervention were compared, significant increases were noted in DMFM, gait speed, cadence, and 6-minute distance after the training. Regarding the long-term efficacy of training, there were significant increases in GMFM immediately after and at the 1 to 3 months and 1 year follow-ups after the intervention. Additionally, significant improvements were noticed in gait speed immediately 1 and 3 months after the intervention. In cadence, immediately 2 months and 1 year after the intervention, and in 6-minute distance 1 and 3 after the intervention. For the participation components, training resulted in improvement in COPM. Here is a graphical representation of the previous tables. Gait speed, cadence, and 6-minute distance improvement were maintained 1 and 3 months after the intervention. Furthermore, GMFM was maintained at the 1-year follow-up assessment. It shows the sustained effect after the intervention in terms of motor function, walking speed, and walking endurance. The present study indicated that wearable cyborg heart treatment may be safe and feasible in patients with childhood-onset motor disabilities. Intervention using HAL in adult patients have indicated that there are improvements in gait speed, stride, cadence, and walking endurance. However, there have been no reports on the long-term effect after robot-assisted gait training using HAL for pediatric patients. Our results suggest that robot training using HAL may be effective for pediatric patients. Thus, HAL appears to be effective as a novel treatment device for pediatric patients. A plateau in motor function in CP is reached at the age of 7 years. And in severe CP below GMLCS level 3, secondary functional decline occurs after age of 7. Most of our participants had adolescent CP with GMLCS level 3 and therefore had a high risk of secondary functional decline in their natural course. Our results suggest that the beneficial effect of wearable robot assist training on the walking performance after the intervention may be maintained longer period. Another advantage of heart training is that improvement has been noticed with fewer repetitions in children than in adult patients. In this study, as few as 12 repetitions of the training clearly produced improvement in walking ability and gross motor function. However, reports show that over 50 repetitions of hard training were required for improvement in adult patients with spinal cord injury. Therefore, the results suggest that adaptation to hard training occurs earlier in children than in adults. The intervention using HAL was an opportunity for child patients to learn normal walking motion, and it appears to indicate improvement in walking performance and GMFM. Wearable robot training for patients with childhood onset motor disabilities may be safe and feasible. Our results suggest that HAL-assisted training may maintain improvement in walking performance and endurance for 3 months post-intervention, and motor function improvement for 1 year post-intervention. Further, wearable robot training using HAL may be effective intervention for patients with childhood onset motor disabilities. Thank you very much for your kind attention. I'm sorry, but I can only speak Japanese, so it might be difficult for me to understand questions from everyone. If you have any question, please contact me by email here. Thank you.
Thank you, Dr. Mayumi Kuroda, for your wonderful presentation. If anyone has any questions regarding the presentation, you can email Dr. Mayumi through her email ID displayed. So thank you once again, Dr. Mayumi, for your wonderful presentation.
Thank you.
Thank you. Okay, by this, we move on to the next presentation. The next presentation is by Dr. Susanna Ezi from King Saud bin Abdulaziz University for Health Sciences, Saudi Arabia. Hello, Dr. Susanna. Are you ready with your presentation?
Yes, hello, I am.
Okay, so I'm making you the presenter. Kindly click on the share button to share your screen.
Okay, is it visible? Hello? Is it visible?
Yes, your screen is visible. Can you make it a full screen? Is that full screen?
Uh,
Okay, okay. Yeah, it's perfect. Please go ahead.
okay, so good morning, everyone. My name is Susanna Ezi, and I'm a medical student from King Salman Abdulaziz University in Saudi Arabia. So I will be presenting my research today titled The Retreatment and Recurrence Rates Following Bevacizumab, Ranizumab, and Aflibercept versus Laser Therapy for Retinopathy of Prematurity. So starting with the introduction, first, what is retinopathy of prematurity? So it is basically a condition of hypoxia-induced abnormal vessel proliferation in the retina. It mainly affects preterm infants. So for decades, the use of laser therapy has been the gold standard. However, recently, anti-VEGFs, or also called anti-vascular endothelial growth factor agents, have been recently widely used because there has been recent studies that has shown that VEGFs could be one of the factors that are inducing this vessel growth. So they've concluded that anti-VEGFs could be a promising therapy for ROP. So our aim was from the study was to conduct a systematic review and meta-analysis that would pool the evidence from these different trials to measure the retreatment and recurrence rates following anti-VEGF agents and comparing it to laser therapy for the treatment of retinopathy of prematurity. So for our methods, we have systematically searched 4 different databases, Medline, Scopus, clinicaltrials.gov, and Cochrane Central. for any relevant RCT that had compared between the anti-VEGF agents of bevacizumab, ranizumab, or aflibercept, and comparing it to laser therapy. So we have assessed the risk of bias for all the included papers using the CASP criteria, where we had two authors independently and in duplicate assess the articles, and any disagreements were agreed with the third author. We have used risk ratios to represent dichotomous outcomes using a random effects model, where we have considered a p-value of 0.05 or less to be significant. So for our results, ultimately we had 6 RCTs included with a total of 610 infants and 1,064 eyes. So as I mentioned earlier, we had two main outcomes, the recurrence and the retreatment. So starting with the recurrence outcomes, it was first defined as new extraretinal vessel proliferation with the condition that there was vessel progression arrest during the follow-up period. So for this one, laser therapy was associated with a significantly lower risk of recurrence than the anti-VEGF agents, as displayed on Figure 1. So if you look at Figure 1 on the upper part of the poster, so we have run a subgroup analysis comparing laser therapy with first ranizumab and then bevacizumab and aflibercept. And as you can see, for ranizumab and aflibercept, the diamond lies on the right side to the line, so favoring laser. Bevacizumab was actually the only one that had favored the anti-VEGF agent. So in total, the pooled effect for the fourth diamond, last one down, the overall effect was actually favoring laser, showing a lower risk of recurrence for the group. Now moving on to the retreatment outcome. So retreatment was defined as requiring a second intervention with a second treatment modality from the baseline of the start of the study to week 24. For this one, laser therapy has also shown lower retreatment rates than the anti-VEGF groups, as displayed on Figure 2. It basically shows the same outcome. So ranizumab and aflibercept also favor laser, while as bevacizumab was the only group that favored the anti-VEGF agent, with the overall effect being for laser. The p-value for this one was less than 0.0001, so it was a significant effect. So we can conclude from this study that laser treatment has an overall lower risk of both disease recurrence and retreatment, but bevacizumab is the only anti-VEGF agent that is actually associated with lower retreatment and recurrence rates when compared to laser therapy. So these are my references if you'd like to scan the BR code, and thank you so much.
Thank you, Dr. Susanna, for your wonderful presentation. Does anyone have any query? Hope there are no queries. Thank you once again, Dr. Susanna Izzy, for your wonderful presentation. And let's move on to the next presentation. The next presentation is by Dr. Stephanie Wenzel from the Imperial College Healthcare NHS Trust, United Kingdom. Hello, Dr. Stephanie. Are you ready with your presentation?
Hi there. Yes, I'm ready.
Okay, I'm making you the presenter. Please click on the share button to share your screen.
Okay. Okay. Are you able to see there?
Yes, your screen is visible.
Brilliant. Okay. So hi there, everyone. My name's Stephanie Wenzel. I'm a doctor working in Northwest London in the UK. I'm a GP registrar. And this post is regarding a project that we did whilst I was working on the Children's Ambulatory Unit in Hammersmith Hospital. The project's entitled Improving Vitamin D Supplementation Rates in Breastfeeding Mothers. And just for some context, a little bit of background on what the Children's Ambulatory Unit is. essentially it kind of bridges an urgency gap in terms of secondary care. So when children are seen by their primary care doctor and felt to need some secondary care input, obviously if the issue is extremely urgent, they go to the emergency department. But if it isn't that seen to be that urgent, they're referred to paediatricians in clinic in secondary care. But that can sometimes take a few months. So if it's felt that that would be too long for the medical complaint the child has, they're referred to the children's ambulatory unit, where we aim to see children in a couple of days to a couple of weeks, depending on sort of the nature of the issue. And so we see children of all ages, but particularly quite a lot of babies, especially babies in the first few weeks of life, and they tend to be referred with issues like feeding difficulties, prolonged jaundice, failure to thrive, sort of things like that. Anyway, that's just a little bit of context, but whilst seeing babies on the children's ambulatory unit, we noticed anecdotally that many of the breastfeeding mothers who attended with their babies weren't taking any vitamin D supplementation. And this just came about through kind of chats with the mums about issues around nutrition for the babies. As many of you, I'm sure, already know, vitamin D supplementation is important for breastfeeding mothers. It can be difficult for the body to make enough vitamin D via sunlight alone and diet. That's a particular problem in the UK because obviously we have quite a cold and overcast climate. A lot of the time people are out and about in coats or warm clothes which cover lots of the skin up. And so at baseline, vitamin D deficiencies are a problem in the United Kingdom. But obviously, when it comes to breastfeeding mothers, vitamin D is crucial for babies in developing healthy bone, teeth and muscle, in preventing conditions like rickets. And there's also some evidence that babies and young children who are vitamin D deficient are more susceptible to sort of common illnesses, viral illnesses, things like that. As a consequence, the Royal College of Obstetricians and Gynecologists here in the UK advises that breastfeeding women take 10 micrograms of vitamin D daily, and that advice is echoed by the NHS, the National Health Service here in the UK. Having noticed anecdotally that a number of our breastfeeding mums attending with their babies weren't taking vitamin D supplementation, we decided to investigate this and see if we could improve it. So in terms of our methods, the project utilised 2 PDSA cycles. In cycle 1, our first cycle, all the breastfeeding mothers, so all of the mothers who attended with young babies in a 1-month period were asked whether they were breastfeeding, and those that were breastfeeding were asked whether or not they were taking vitamin D supplementation. If they weren't, we just gave some verbal counselling about the importance of taking supplementation, some advice about where they could find appropriate supplements, how much to take, things like that. We then followed up these mothers with a phone call a week later to see how they were getting on and see if they'd started taking some supplementation. So as you can see in figure 2 down here, sort of these were our numbers, but to summarise things, in cycle 1, 69% of the breastfeeding women were taking vitamin D supplementation already prior to our intervention, but after our intervention 96% were. So we were pretty pleased with that. We thought that was a fairly good outcome. But when we were talking to the mothers in our follow-up phone calls with them, a lot of them said to us, you know, they were happy to hear our advice, but actually it was hard to keep track of the advice they were getting from healthcare professionals because, as I'm sure you can all imagine, caring for a newborn is a pretty busy time for mothers. And certainly in the UK, they often have many different appointments they have to go to with healthcare professionals, and they get lots and lots of advice. And so a lot of them were saying, you know, it's just a bit difficult to keep track of all these things. Something like a handout or a leaflet might be quite helpful, just as a bit of an aid memoir. And so for our second cycle, we decided to add in a leaflet, which is what we did. You can see the leaflet here in figure 1. Essentially, the leaflet just detailed what vitamin D does, what are the effects of deficiency, where it can be obtained from, and how much should be taken. The other thing we also made sure to include was some information for mothers who are eligible for support. So a number of the mothers we spoke to who were from lower income backgrounds and households said to us they recognised the importance of taking supplementation, but they were concerned that, if they were going to be breastfeeding for a long time, the cost of that might stack up quite a bit. And so wanted to know if there was any option for them to receive free vitamin D or some help with that. And the answer to that question was yes. And so we included some information about where they can find that information, the link to the Healthy Start NHS campaign, and a QR code they can scan, because a number of them would be eligible for free vitamin D supplementation. So when we moved on to our second cycle, all of the breastfeeding mothers who attended in a 2-month period were asked whether or not they were taking vitamin D. And if they weren't, in addition to verbal counselling, we also provided them with the information leaflet. And again, followed them up with a phone call a week later to see how they were getting on. So in terms of the results from cycle 2, we actually had a higher percentage of women already taking vitamin D prior to our intervention. It was at 86% in cycle 2, but after our intervention, 100% of the breastfeeding women were taking vitamin D supplementation. So again, we were really pleased with that. We have plans to do a third cycle of this project, mostly revolving around improvements to the leaflet. Some of the women we spoke to had some advice for us. One of the big things that came up actually was advice regarding sort of specific brands and things over the counter that could be bought, whether or not there was anything in particular we recommended, because a lot of the women would find it a bit sort of muddling when they would go into a chemist or a pharmacy and find sort of many different brands and options for them to take. And so that's certainly a change we're going to make, in addition to a few others. But yes, we were pleased that we were at 100% after our intervention in cycle 2, and we'll take on that third cycle. So in terms of our sort of conclusions and recommendations, then obviously the medical consensus is clear that vitamin D supplementation is important whilst breastfeeding, but a significant minority of women who are breastfeeding are not taking it. And certainly something that came through was that, caring for a newborn is an exciting time for a family, but it is also a very, very busy time. And as I said, for women in the UK, often there's many appointments necessary with healthcare professionals. They're seeing their GP, the practice nurse, seeing us on the children's ambulatory unit, the health visitor. If they had a complicated delivery, they might also still be seeing the obstetrician. So there's an awful lot going on for them, and they're getting lots of different advice and guidance that can feel a bit challenging to keep track of. So I think providing women and families with documents, leaflets and things like that can be quite helpful, just as a memory jog, and for them to keep track of all of these different pieces of advice. The other sort of conclusion we spoke a lot about as well was sort of the importance of taking opportunities. So one way we saw this was just the opportunity that we could take with the discussion of vitamin D supplementation, often brought about further dialogue about other important topics such as childhood nutrition and supplementation in infants generally. Just that discussion around vitamin D opened that door, and we found ourselves having discussion with mums about general issues around childhood nutrition. Lots of them had questions about weaning, about what sort of foods are appropriate when weaning, what the best age to start weaning is, and all these other queries that we hadn't anticipated, but sort of just this discussion about vitamin D opened that door. And then again, in terms of taking opportunities, it was a learning point for us that although the children's ambulatory unit is a paediatric service and we're not directly involved in maternity care, actually it was a good opportunity to speak to the mums about how they were getting on. And obviously when it comes to things like breastfeeding, a mother's health is very much linked to the health of their baby. And for us, it was sort of the importance of not having the blinkers on and only focusing on the baby and the issue they've presented with, but actually taking the opportunity to speak to the family, and particularly in this case, the mother, about their own health and their own well-being. And yeah, really recognizing the importance of that professional curiosity into the well-being and health of the breastfeeding mothers, as well as focusing on the baby. But yeah, thank you very much for listening and giving me this opportunity to present my poster. We've got our references down here, and I'd be happy to take any questions. But yeah, many thanks for this opportunity.
Thank you, Dr. Stephanie, for your wonderful presentation. Does anyone have any query? Okay, hope there are no queries. Thank you once again, Dr. Stephanie, for your wonderful presentation.
Thank you.
Thank you. Okay, let's move on to the next presentation. The next presentation is by Dr. Viveka Singh from the Dr. L.H. Hiranandani Hospital and Research Center, Mumbai, India. Hello, Dr. Viveka. Can you hear me? Hello, Dr. Viveka. Are you ready with your presentation?
Hello.
Hello, Dr.
Yes,
Viveka.
can you hear?
Yes, you're
Can you go
audible.
ahead with my presentation, please? Yeah.
Yes, you're audible. Okay, I'm making you the presenter.
Yes, I have sent
Should
you the PPT. Yeah.
Okay. We will share the screen from our end then.
And please let me know anytime when I'm not audible so that there's no confusion there.
Okay.
Have you shared the PPT?
No, Dr. Viveka, not yet. Please give
Yeah,
us a
yeah,
minute.
please. Yeah, sure. Take your time.
Hello, Dr. Viveka. Is the screen visible from your end?
Yes.
Okay, please go ahead with your presentation.
Yeah. Good evening. Thank you so much for all the assistance so far. This is Dr. Viveka Singh from Mumbai, India. I'll be presenting my case report of William-Barron syndrome, which is a rare case report. So, initially, I would like to firstly thank and extend my sincere gratitude to the ECPN team for giving me this kind of opportunity for the consecutive second year of 2023 and giving this global platform, of course, to present this medical work of mine on the stage. And thank you so much for that, and to all the fellow ECPN members. Thanks a lot. So, beginning with the case, firstly, I'll begin with the abstract, that is the Williams syndrome, as we know, is a rare congenital multisystem genetic disorder, which is suspected based on its characteristic facial features, number one, elephant facies, but is often unrecognized during neonatal period, and complications may progress prior to diagnosis. we report a rare case of Williams syndrome, also known as William-Barron syndrome, diagnosed at 2 months of age, whose physical examination demonstrated subtle facial dysmorphism and pulmonary systolic murmur at birth. Moving on to the next slide, kindly. Yes, it's a continuation of the abstract here. So we had performed an echo at 1 month of age for this infant at 1 month, almost reaching the infancy period and completing the neonatal period, which showed an atrial and ventricular septal defect, moderate pulmonary artery stenosis, and a repeat echo on follow-up at 2 months of age revealed evidence of mild supravalvular aortic stenosis and mild supravalvular pulmonary stenosis. This gave us a clue further in combination with basically the subtle dysmorphism and also the echocardiographic findings to strongly suspect facial dysmorphism and cardiac abnormalities, as I said, as Williams syndrome. So these were the two main clues for us to strongly suspect this syndrome. And also we noted mild developmental delay and failure to thrive in this infant. It was confirmed by FISH, which is fluorescence in situ hybridization test, which is demonstrating a deletion of elastin gene on chromosome 7. This case highlights the importance of pediatricians' awareness about malformation syndromes, which can help in early diagnosis, timely genetic counseling to the family members, and better patient outcomes. Can you please go back to the previous slide? Yes. Sorry, can you go to the next slide? Yeah. The second slide, please. Thank you. So coming to the introduction here now, as I said, Williams syndrome is a rare congenital neurodevelopmental disorder occurring in 1 per 25,000 live births. That is the incidence. It is characterized by facial dysmorphism, cardiovascular, renal, gut, and skeletal anomalies, mental and growth retardation. The phenotype is characterized by short stature and craniofacial abnormalities. It is associated with microdeletion in chromosome region 7q1123, encompassing the elastin gene. Can you please go to the previous slide one? So as you can see clearly the image of the neonate. Now this image is of the neonate at the time of birth, which we have taken, and you can actually see by the facial features that there is certainly pointing towards some facial dysmorphism, although these are subtle facial features. Because in neonatal period, you cannot actually pick up gross facial dysmorphism, but definitely subtle features. Now coming to the case report, a female neonate was born to a 32-year-old second. The first slide, please. I want the first slide, please. Yes. Now coming to the case report, a female neonate was born to a 32-year-old second gravida woman at 34 plus 5 weeks of gestation, spontaneous conception, dichorionic twin pregnancy by cesarean section in view of premature labor, and cord prolapse on 30th May 2020. Apgar score was normal and birth weight was 1900 grams. Neonate required non-invasive ventilation due to moderate respiratory distress at birth. On general examination, subtle facial dysmorphism, as you can see in figure 1, in form of broad forehead, flat nasal bridge, long philtrum, and wide mouth were noted. A pulmonary ejection systolic murmur, grade 3 by 6, was heard on second day of life. Rest of the systemic examination was unremarkable. Kindly go to the slide 3. Thank you. 2D echo detected ventricular and atrial septal defect, moderate pulmonary artery stenosis. Cardiologic follow-up was advised at 2 months of age by the pediatric cardiologist. So there was now an involvement of multidisciplinary team approach here. Besides the neonatologist, there was an involvement of pediatric cardiologist as well, because of the signs and clues we got at the time of birth. Abdominal, renal, and cranial ultrasound findings were normal. Primary metabolic screen and serum calcium levels were also normal. Screening for a time of prematurity was normal. Hearing and eye screening was found to be normal. Baby was discharged by 12th day of life on breastfeeds, formula feeds, and supplements. At 2 months of age, echocardiogram showed mild supravalvular aortic stenosis, mild supravalvular pulmonary stenosis with significant branch pulmonary artery stenosis, patent foramen ovale, and normal biventricular contractility. As there were no signs of cardiac hypertrophy or heart failure, no active intervention was advised by the pediatric cardiologist. Williams syndrome was strongly suspected due to a combination of facial dysmorphism and cardiac anomalies as early as you can say by 2 months of age. It was confirmed by FISH test, which demonstrated a deletion of elastin gene on chromosome 7. The FISH test was performed by 2 months of age by us. And also genetic analysis of both the parents were also done, which was normal. On cardiologic review after 3 weeks, follow-up after 1 year was advised. From cardiac point of view, baby remained asymptomatic. Constipation and feeding difficulties led to failure to thrive. Mild developmental delay and hypotonia were observed. Early intervention programs were started as advised by the pediatric neurologist, which was also involved in form of oromotor, occupational, and speech therapies. At 1 year of age, 2D echo showed no significant supravalvular aortic stenosis, and mild right pulmonary artery stenosis. Cardiologic follow-up after 3 years was recommended. So here goes the importance of follow-up, eventual follow-ups of the cardiologic and reviews along with the echocardiograms. Repeat auditory test was normal. Serial evaluation on regular follow-ups showed a steady improvement in feeding, growth, and developmental milestones, speech, and school performance. Coming to basically the first slide. Yes. So now we'll go to the discussion. We begin basically now. What are the main features and how did we come to the diagnosis of Williams syndrome? And how early can we detect it? Usually it is detected in the period of infancy when the features are very prominent via the facial features and also other systemic features are prominent. But here we were able to detect as early as by 2 months, and that is why we wanted to report this case. So Williams syndrome affects male and females equally. A clear genotype-phenotype correlation has been established in Williams syndrome for elastin gene, which is responsible for vascular and connective tissue disorders. Combination of a typical clinical phenotype and echocardic profile aids in the diagnosis. However, the confirmation of diagnosis carried out by FISH test. Elephant facies consist of prominent metopic suture, small chin, sunken nasal bridge, eye puffiness, wide mouth, and prominent lower lip. Facial dysmorphism can be subtle early in life and may lead to difficulty in diagnosis. Can I move to the fourth slide, please? Yes, so this is very clearly, as you can see, the neonates FISH report, as you can see, which is the figure 2, and it shows the evidence of the deletion of the elastin gene chromosome 7, that is the region 7q1121. So this is the proper investigation report as displayed here to you. And also the figure 3, which is the regular follow-ups which we have been doing of the child and seeing his growth, developmental milestones, feeding patterns and everything, and scholastic performance as well. So this is the image of a happy infant at 3 years of age. Can we go to the next slide, please, for the continuation of discussion? Yes. So during neonatal and infancy period, cardiovascular manifestations are most common in Williams syndrome and help in making an early diagnosis when other features can remain unrecognized. Most frequent anomalies are supravalvular aortic stenosis, or these are the most frequent cardiac anomalies, are supravalvular aortic stenosis or supravalvular pulmonary stenosis. A detailed cardiovascular screening include fall in BP, blood pressure, and echocardiogram, which must be performed. Patients with supravalvular aortic stenosis are diagnosed during evaluation of an asymptomatic heart murmur. We got the murmur on the second day of life. So supravalvular aortic stenosis is a common cardiac anomaly occurring almost 64%, of which 30% require surgical corrections before 5 years of age. Other lesions include mitral valve prolapse, pulmonary artery stenosis, which is 15% mitral valve prolapse, pulmonary artery stenosis 13%, that is the occurrence, coarctation of the aorta 8%, aortic hypoplasia, ventricular or atrial septal defects, which also can occur. Besides, diagnosis is even more relevant to prognosticate, since when cardiac interventions are possible, the prognosis is usually good and operative mortality is low. Infants are often small for gestational age and show intrauterine growth retardation antenatally, whereas this child did not show any features of intrauterine growth retardation. Vomiting, gastroesophageal reflux, constipation, excessive irritability are common in infancy. We did see the evidence of constipation and feeding difficulty in our child, leading to failure to thrive. Patients may develop hypertension because of renal artery stenosis and infantile hypercalcemia, leading to nephrocalcinosis. We did not see evidence of high serum calcium levels in our neonate, neither did we document any evidence of hypertension. So renal ultrasound with Doppler is routinely obtained to screen for renal artery stenosis. Regular monitoring of serum calcium levels is recommended. Hypercalcemia is managed by low calcium diet and no supplementation of vitamin D. Neurocognitive profile commonly includes mild mental retardation. Cognitive strengths and weakness relative to other patients with mental retardation include relatively good auditory rote memory, but extreme difficulty with visuospatial construction tasks. So Williams syndrome is diagnosed by primary clinical findings such as elephant face, congenital heart defects, and neurocognitive defects. Annual evaluation of every child should include growth and developmental assessment, blood pressure monitoring, auditory and vision screening, cardiovascular evaluation, look for progressive vascular stenosis, as recommended by American Academy of Pediatrics. So this is the case report for Williams-Barré syndrome. And here I conclude my case report. We can go to the next slide kindly for the lessons learned, please. The last slide. Yes. So finally, the lessons which we learned from this are: number one, Williams syndrome should be kept as a differential diagnosis in infants and children presenting with facial dysmorphism and cardiovascular anomalies. Detailed cardiovascular screening must be performed in presence of a distinctive facial phenotype. Early cardiac interventions yield a better patient outcome and a good prognosis. Multidisciplinary team approach and implementation of early intervention programs lead to a successful neonatal outcome. And those are the references below. This is my case one, which is Williams-Barré syndrome. Thank you. Any queries, any questions? I'm open to answer.
Thank you, Dr.
Am I
Viveka
audible?
Singh, for your wonderful presentation. Does anyone have any query? Okay, hope there are no queries regarding the presentation. Thank you,
All right.
Dr. Vivek Singh, for your
Thank you so
wonderful
much.
presentation. And we would like to ask you, as there are two presentations of yours,
Yes. Yes.
yeah, are you ready with the next presentation? I
Yes,
mean,
I am
next
ready with the next.
topic?
We can go ahead with the
Okay, you
next,
can.
definitely.
Yes, yes. So have you shared the
I have shared the
presentation?
PPT, so if you could kindly share it
Okay,
from your end, please, the second one.
sure.
Yes.
Give us a minute.
Yes.
Hello, Dr. Viveka Singh.
Yes.
Are the
The screen is
slides
visible to
visible?
me. Yes. So, and am I
Okay.
audible to you?
Yes, you're audible. Please
So,
go
should I
ahead.
go ahead with my case 2 presentation?
Yes, please.
Yes. All right. Thank you so much. So, I go ahead with my case 2, which is the intestinal malrotation with midgut volvulus in a neonate, a case report. So, starting from the abstract, intestinal malrotation is a congenital abnormal fixation of the bowel that predisposes to life-threatening midgut volvulus. It is a rare congenital abnormality with diverse outcomes. If cecal, which is also known as Lard's bands, are present or midgut volvulus ensues, neonates may present with symptoms of intestinal obstruction, such as bilious emesis or signs of ischemic bowel, like bleeding per rectum. If not treated expeditiously, volvulus can progress to ischemic gut necrosis, sepsis, and death. So moving on to the second slide. Yes, it's a continuation of abstract here. So upper GI series has been the preferred imaging modality, although ultrasound has been introduced as an alternative method for the diagnosis of malrotation. It has proven to be more accurate these days. The whirlpool sign is an imaging characteristic of midgut volvulus and has a high predicting value for volvulus. Open labs procedure is a standard treatment. We report a rare case of midgut malrotation with volvulus with whirlpool sign in a neonate with history of frequent bilious emesis. Diagnosis of intestinal malrotation was confirmed by abdominal ultrasound and open labs procedure was performed. Post-operatively, neonate had a shorter hospital stay, rapid recovery of peristalsis, and early restoration of oral feeds. We aim to highlight that familiarity with variations in presentation of malrotation is imperative as early diagnosis and prompt surgical intervention are essential to optimizing outcome. Can I kindly move on? Before I move on, I'll go ahead with the introduction. So, intestinal malrotation, as I said, is a congenital abnormal fixation of the bowel that predisposes to life-threatening midgut volvulus. It is a rare congenital abnormality with diverse outcomes. Now, coming to the incidence, malrotation is estimated to be present in 1 in 500 live births. Volvulus is seen in 60 to 70% of neonates diagnosed with intestinal malrotation. Associated congenital anomalies are high, up to 60%. If not treated expeditiously, volvulus can progress to ischemia, sepsis, and death. Can I move on to the previous slide, slide 1? Yes, thank you. So here I begin with the case report. A male neonate born to a second gravida woman at 37 plus 3 weeks of gestation, born by vaginal delivery, who weighed 3.01 kgs at birth, presented on day 7 of life with complaints of frequent yellowish green vomiting and yellowish discoloration of skin. Vitals were normal, abdomen was mildly distended, bowel sounds were heard with no guarding rigidity. Baby was admitted in neonatal intensive care unit, kept nil by mouth, started on IV fluids, antibiotics, along with supportive treatment. Phototherapy was initiated in view of neonatal jaundice. Coming to the next slide, that is the third slide. Thank you. Abdominal X-ray was performed initially, revealing a mild stomach distension and bowel dilatation over the left quadrant area, suggestive of a possibility of malrotation. Can you go ahead with the first slide? I want to show the X-ray of the abdomen to the fellow doctors. Yes. So there's a figure 1, as you can see, preoperative X-ray of the abdomen. As you can see, there's mild distension of the gas bubble here. This is the region where you can see the gas bubble. And also this is the area onto the left side, the quadrant of the dilated gaseous bowel loops, which are very much evident on the X-ray, suspecting malrotation. Going on to the slide 3 again. Yes. Following that, since we suspected malrotation, we went ahead with an abdominal ultrasound demonstrating wrapping of the superior mesenteric vein and bowel loops around the superior mesenteric artery, which is known as whirlpool sign, showing evidence of midgut malrotation. Liver function test was normal. Surgical repair was advised by pediatric surgeon. Untwisting of volvulus was performed, followed by Ladd's procedure in view of malrotation of gut on 20th June 2023. Intraoperative findings include malrotation of gut with volvulus and no evidence of bowel perforation or ischemia or necrosis. Postoperatively, baby was kept nil by mouth and continued on IV fluids. Antibiotics and supportive treatment was given. Greenish aspirates from the RT, that is Wright's tube, was noted, which was replaced by ringal lactate solution. USG abdomen was also followed up postoperatively as well on postoperative day 1, which was unremarkable. Saline wash was administered in view of one episode of melena postoperatively with fresh blood, which was noticed in the RT aspirates. The neonate received one FFP transfusion, that is a frozen plasma, and also injection vitamin K, fresh frozen plasma, and injection vitamin K besides injection Rantac. Liver function test repeated post-operatively was normal. No further bleeding manifestations were noted, nor any persistent recurrent bilious vomiting was noted. Feeding was started on post-operative day 7, which was well tolerated. Incision site remained healthy and clean. Neonate was discharged on day 16th of life on oral antibiotics and supplements. Can I move on to the next slide, please? Yes, so these are the images, as you can see, figure 2, which is, as I mentioned, on the abdominal ultrasound, which shows the whirlpool sign. This is the USG and the Doppler, which is evident in front of you. And the area which is marked in front of you, that is in the green box inside, that shows the evidence of whirlpool sign. That sign is very characteristic and diagnostic rather, both prognostic and diagnostic for intestinal malrotation. It is a very crucial sign, and it is the diagnosis of intestinal malrotation. Coming to the figure 3, as you can see the intraop images here, that is basically taken in the operation theater basically. So you can see as labeled by us, which is basically the appendix onto the one end. There is also the cecum ascending colon at the upper end and also the small bowel at the lower end. And the other image as well, these are all the intraoperative images showing the evidence of basically the malrotation. And basically, as I said, ultrasound diagnosis of intestinal malrotation is a main thing which we need to perform. And it is all about the positional relationship of the superior mesenteric artery to determine whether there's malrotation. So normally, it's very important for us to know the relationship of the superior mesenteric artery and the vein is approximately parallel in nature. Once the relationship between the SMV and the SMA is reversed, the SMV is located on the front left of the SMA rather than the ventral and the right sides, then that is known as malrotation of intestines. Can I move on to the first slide, please? Yes. Now coming to the discussion, I will go ahead with the discussion of this case. So congenital intestinal malrotation is due to obstruction of intestinal rotation during embryonic development complicated by intestinal obstruction or intestinal volvulus. It can happen with either obstruction or volvulus, either or. So during embryonic gut development, fetal, this is about the embryology, what I'm talking about. So fetal midgut undergoes 270-degree counterclockwise rotation around the axis of the superior mesenteric artery between 4th and 8th weeks of gestation. Partial or complete failure of this rotation during embryogenesis leads to intestinal malrotation abnormalities. Midgut volvulus refers to the twisting of bowel loops around the mesenteric artery. Can we move on to the fifth slide, please? Yes, it's a continuation of discussion here. It may lead to catastrophic complications, including intestinal obstruction, bowel ischemia, necrosis, perforation, and peritonitis. Prompt diagnosis is vital to prevent undesirable neonatal outcomes. Due to different degree of duodenal compression, it can manifest as partial or complete obstruction. In the partial obstruction, patient will have intermittent bilious emesis with no abdominal distension. Very important point to remember. Whereas when obstruction is complete, frequent biliary vomiting will continue, accompanied by dehydration, weight loss, and constipation. If it is complicated by midgut volvulus, symptoms will be even more serious and may cause small bowel necrosis, perforation, peritonitis, and shock. USG findings of midgut volvulus include dilated intestinal loops and the classic whirlpool sign, which refers to the winding appearance of the mesentery and superior mesenteric vein wrapped around the superior mesenteric artery, as already displayed to you in the figure 2. USG Doppler is not only predictive, but also diagnostic of malrotation with an advantage of no radiation exposure. It has a high sensitivity and specificity for the detection of midgut volvulus. Detection of midgut volvulus warrants an urgent neonatal surgical intervention. Operative management consists of derotation, widening of mesenteric base, division of Ladd's bands, and incidental appendicectomy may be performed. As in our case as well, it was performed. Postoperative complications include wound infection, adhesions, sepsis, feeding intolerance, recurrent volvulus. In absence of associated anomalies, isolated midgut volvulus has a favorable prognosis post-surgery. So eventually, prompt diagnosis and surgical intervention are vital to reduce the morbidity and mortality associated with this condition. Can we move on to the last slide, please? Yes. So lessons learned from this case. Intestinal malrotation with or without volvulus must be suspected in every neonate presenting with frequent bilious emesis and poor feeding. Sonographic whirlpool sign is a valid and highly sensitive sign for diagnosis of midgut volvulus secondary to malrotation. Rapid diagnosis of malrotation by USG helps to allow for urgent surgical intervention to avoid bowel necrosis and provides a favorable outcome. And these are the references as quoted by me below. So this is my second case presentation of basically intestinal malrotation with volvulus in a neonate in our hospital center. Thank you so much. Any queries and questions, I'm open to answer, please.
Thank you, Dr. Viveka Singh, for your wonderful presentation. Does anyone have any query? Okay, hope there are no queries. Thank you once again, Dr. Viveka Singh, for your
All right.
wonderful
Thank you so much. And I
presentations.
would like to thank the entire team of ECPN and also the members who have helped me so much with all my queries and doubts so far efficiently and timely. Warm greetings from India. Namaste to all. Thank you so much. Have a good day ahead.
Thank you. Thank you so much. Okay, let's move on to the next presentation. The next presentation is by Dr. Rabia Yunus from Pittsburgh City Hospital, NHS, United Kingdom. Hello, Dr. Rabia. Are you ready with your presentation?
Hello, hi. Yeah, you can please share the my poster
Oh,
screen.
sure,
Mm-hmm.
sure. We will share the screen from our end. Give us a minute.
This conference will now be recorded.
Hello. Hello, Dr. Rabia. Can
Yeah,
you hear me?
yeah,
Yes. Is it possible to share the screen from your end because we are unable to share your poster? Is that possible?
yeah. I continue.
Okay. Yeah, I'm making you the presenter. Please click on the share button to share your screen.
Okay, can you see the poster?
No, it's not shared yet.
Okay. Um,
Kindly click on the share button. After that, please click on the entire screen option. Yes, your screen is visible. Can you open your Yeah, please make it please place your mobile in a landscape mode so that,
yeah, I'll do it. Just give me 1 second.
sure.
Sorry. Can we see?
Yeah, that's perfect. Please go
Okay.
ahead. It's
Hey,
perfect.
my name is Rabia, one of the doctors. I'm working in a Peterborough City Hospital as Obstetrics and Gynecology Registrar. Thank you very much for giving me an opportunity to present, and apologies if you hear any background noise. I'm just in the middle of a clinic. So my poster is a brief overview of a case report of intramyometrial ectopic pregnancy with a hematometra on a background of adenomyosis. Regarding just a quick overview, it's intramyometrial ectopic pregnancy is very rare and it is about less than 1% of all pregnancies. It means a pregnancy, a gestational sac which is located within the myometrium with no connection to the endometrial cavity or fallopian tubes. What we did, we used 3D TV scanning to determine the location of the sac and also beta HCT to diagnose it. If we talk about our results, we would like to tell about the contributing factors. Ideally, most are traumatic that can lead to this kind of pregnancy. Adenomyosis, although it is non-traumatic, it can disrupt the endometrial lining and can still cause this kind of pregnancy. The pathophysiology includes leading to the formation of microscopic tract into the myometrium and contributes to defective decidualization of endometrial stromal cells. Combined with increased trophoblastic activity, these factors can explain the formation of such an ectopic pregnancy in a primary gravida patient with no history of uterine surgeries or IVF. We present a case of 32-year-old female who came in with vaginal bleeding, passing clots, and a pregnancy test that was positive a week earlier. She had a beta HCG of 31,270, and a 48-hour later, it was not doubled up to more than 50%. It came out to be 38,417. We did a TV scan which showed anteverted and retroflexed uterus with a significant hematometra and with a no Doppler sign. A gestational sac was visible with a tiny fetal pole and no fetal heart. Then she had a third beta HCG 48 hours later, which was 45,032. As you can see the pattern, all the three beta HCGs, they are rising more than 50%. The repeat TV scan shows the diagnosis of complete intramyometrial pregnancy with a fluid-filled structure and a solid residual reaction within the myometrium close to the interstitial part of the tube, and there was no fetal heart present. We made the diagnosis of intramyometrial ectopic pregnancy. There was significant vascularity present around the structure. So the patient underwent a surgical procedure, surgical curettage under ultrasound guidance. The curette was directed towards the trophoblast, leading to the removal of the sac. The specimen was sent to histopathology, which later confirmed the trophoblastic nature of the cells. The repeat beta HCG after the procedure the next day came out to be 14,594. A week again later, the beta HCG of 998 was seen. The scan showed adenomyosis with post-evacuation changes within the myometrium where the sac was located. Hematometra was resolved completely. So as you can see, this is one of the cases among the ectopic pregnancy. It constitutes less than 1% of the pregnancies. So we made the diagnosis combining both the beta HCG and the scanning result, and it fits the clear picture of exact diagnosis. Apart, just exception for this patient is that she had a diagnosis of adenomyosis on the background. In conclusion, the diagnosis of intramural pregnancy is challenging to establish and easy to miss. There is no defined gold standard investigation. MRI and TV scans are used in the diagnosis. There is a growing use of 3D TV scans. The diagnosis is finally confirmed by histological findings of villus and trophoblastic cells in the myometrium. There are different treatment reported for intramyometrial ectopics. Cases that reported early diagnosis of ectopic showed satisfactory resolution with conservative management, or we can use systemic or localized injection of methotrexate followed by serial beta HCG monitoring and a repeat scan to confirm that resolution has mainly occurred. There is one report of case of uterine artery embolization with satisfactory result and maintenance of patient's fertility. Other invasive treatment options you could use operative hysteroscopy, laparoscopy, either open wedge excision or laparoscopic or open hysterectomy. Thank you very much. I have given some references down below of my rare case of intramyometrial ectopic pregnancy.
Thank you, Dr. Rabia, for your wonderful presentation. Does anyone have any query?
Can you hear me? Does anyone have any questions? Thank you very much for giving me the opportunity again.
Okay, hope there are no questions. Thank you once again, Dr. Rabia Yunus, for your wonderful presentation.
Thank you.
This conference will now be recorded.
Hello everyone. By this we came to the end of day 2 webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoyed the webinar and gain knowledge from the sessions. And we'll be glad if you could join us in next in-person conference or webinar which is scheduled, and the dates will be informed to you by email. We'll be very happy if you could share your opinion or feedback with us. And thank you, everyone. The presentations were quite engaging and they were quite interesting. Thank you very much for your wonderful presentations and for your patient listening. Thank you, everyone. Have a great day.
Thank
Thank
you.
you. Thank you so much for giving this opportunity.
Thank you. Thank you,
Thank you
Doctor.
so much.
Thank you, Dr. Talib.
Thank
Thank
you.
you.